And the session today is called Session 6A, Research and Innovation for Global Health. Please welcome the moderator of this session, Professor Martin M. Nyaga from the University of the Free State, South Africa. Until he arrives. You applaud until he arrives. Thank you very much. Welcome, Professor Martin M. Nyaga. And in the same time, I will call and invite Professor Marlene Tamerman from Aga Khan University, Kenya. Also, I will invite all the presenters of this session, and I begin with Dr. Euclides Sacomboyo from Universidade Agostinho Neto, Angola. Online or virtual? Oh, okay. So applause him, please. He needs encouragement, so. Hello. How we say good morning in Portuguese?
Bom dia.
Bom dia. Okay. And Dr. Hyacinthe Towe from Centre National de Recherche et de Formation sur le Paludisme from Burkina Faso. Welcome. Next, Dr. Ngu Abanda from Centre Pasteur of Cameroon, Cameroon. Online, okay. And next, Dr. Leiti Gay Thiam from Institut Pasteur de Dakar, Senegal. And last, Dr. Protus Arey Tarkang from Institute of Medical Research and Medicinal Plants Studies from Cameroon. So I like to Professor Martin M. Nyaga the moderation of this session. And if you need, microphone is here.
Is this one working? Okay, good. Thank you so much, MC, for the introduction, and welcome my panel for today. My name, as you've heard, is Martin Nyaga from University of the Free State in South Africa. I'm a medical virologist by training. I also serve as the director for the WHO Collaborating Center for Vaccine Preventable Diseases, Surveillance and Pathogen Genomics. I also chair the VPD focus group for the African CDC. Africa's large burden of disease and a developing healthcare system presents a great opportunity for innovation and solutions to address the global health challenges. For instance, emerging digital health technologies across sub-Saharan Africa have made the region a breeding ground for global digital health. The digital innovations, such as the utilization of drones to deliver medicine to remote areas, are contributing to solutions aimed at addressing challenges around patient management, as well as disease surveillance and prevention in Africa. To sustain the gains made in and accelerate the march towards addressing Africa health challenges, enhanced investment in health research and innovation capacity strengthening is paramount. Specifically, the investment should focus on addressing gaps in financing health research, health systems, South-to-South collaborations, human and infrastructure capacity, skills and knowledge management, as well as global recognition of Africa research and researchers as envisioned in Africa's 2018 to 2030 Health Research and Innovation Strategy for Africa. One of the strategic objectives of the health Research and Innovation Strategy for Africa is to strengthen capacity for sustained, integrated, coordinated, and collaborative research, innovation, and translation for health. And here, Africa seeks to, among others, develop its human capacity for sustained health research and innovation. It also seeks to support the generation of new knowledge and its translation into services, products, policies, and practice to improve health. In so doing, the continent hopes to drive its health and well-being through Africa-led research and innovation. In this session, thus, we provide opportunities to highlight success stories, lessons learned, opportunities and imperatives for enhanced scientific cooperation and productivity in contribution to addressing the outstanding grand challenges in Africa health space. With these delegates and guests, we want to welcome our keynote presentation on grand challenges and opportunities in global health, that is perspectives from the AU-EU policy study on health. And I will let my colleague, Prof. Mariam Tamaman from Aga Khan University, to come and give the keynote and also introduce herself more on that. Thank you and welcome.
Sorry, before introducing Professor Marlene Temmerman, excuse me, just I forget to say that Dr. Etienne Bilgo from Institut de Recherche en Sciences de Santé from Burkina Faso is also with us online. So I forget the name. Sorry. Thank you.
Thank you, MC. We also have him to present at the end. Prof, can you give a round of applause for Prof. as she comes?
Thank you very much, Martin. And sorry for arriving late. I only came yesterday evening, but I'm so happy, thanks to the African Academy of Science for inviting me, and I'm very happy to be here with you today. The title is indeed the report, The Grand Challenges and Opportunities in Global Health. It's on a report that I was involved in together with some colleagues, commissioned by the EU and the AU on global health. I'm going to introduce myself a bit. I'm a medical doctor in obstetrician gynecologist and trained in public health. Belgian national, but spent more years of my life in Africa, actually in Kenya most of the time, in academia. From Ghent University in Belgium, also University of Nairobi, where I started my research career in the area of HIV/AIDS, as many of us of my age, in 85 in Nairobi. But I've also, so most of my life in academia, but also spent some time in politics, as I was an elected senator in my own country. And that was never the plan and the intention to go into politics, but I was invited, accepted the invitation to run, and was elected. And the reason why I'm bringing that up is that it's nice and it's good to learn how to work in other constituencies. I learned a lot being 2 terms in politics, because from research we bring the evidence and the data, but then much more is needed to make a difference in the field. And I'm happy to have this kind of background as well. From there I went to the UN in New York first to help in a team with Secretary General Ban Ki-moon on an assessment of the MDGs in 2010, trying to figure out what works well and what should go better. And also this is a good learning experience, to then join WHO in Geneva as the director of the Women's Health and Research Unit. And retiring from Geneva, I went back to my second home country, to Kenya, about 8 years ago, to join the Aga Khan University and continue actually the research, but trying not only to do the research, but also translation into policies, guidelines, and an impact in the field, because that's, I think, is the most difficult area. I'm also UNESCO chair and a very proud international fellow of the African Academy of Science, also the American Academy of Arts and Science, and the National Academy of Medicine. Now, in 2021, I was invited by the EU, the European Commission, the RTI section, to join a group, an advisory group on research and innovation. And I'm going to take you through that report. The 4 topics identified by the EU, together with the AU, because it's a kind of a joint effort, were the African-Europe cooperation in the health sector, and I'm going to focus on that one because that's my area of expertise. Number 2, strengthening research and innovation capacity in Africa for regional and bilateral cooperation. Number 3, innovation and technology revolution. And number 4, the green transition in Africa. So this was actually the package commissioned by the European Commission, Research and Innovation, and the African Union. And we worked with 2 leads per topic. So we had a lead from Europe, a lead from Africa for all these topics. Mine was on the health sector. The team here, and I'm very happy to, because it's a pity that they are not here today, but the 2 main collaborators actually are from Tunis, from Institut Pasteur. And I'm sure, I hope that they are online and maybe they are willing to join us. Here you see the names. So we had Prof. Sonia Abdelhak, who is very well known here, I think. She is a senior biologist of the Institut Pasteur de Tunis, and she is leading research laboratory on biomedical genomics and oncogenetics. And she was assisted by Dr. Yosher Hamdi, who is a doctor in molecular medicine and an assistant researcher in the same institution. And my assistant was Nella Ndaka. So we got our terms of reference, the theoretical framework, what you are supposed to do. I'm not going to read everything, but just the keywords. So the mandate, the task was actually to have sound evidence and to assess the progress that was made so far on research and innovation policies, development and activities, and identify regional important issues that must be addressed to strengthen the collaboration between Europe and Africa in terms of research in these 4 areas. Outline policy recommendations, and then develop a roadmap. So we had to, that was for the 4 groups actually, we had the similar mandate. So research and innovation, we looked also at ethics and regulatory environments and bridging the gaps between research, innovation, and policy-making mechanisms. Strengthening of health research and innovation, epidemic preparedness, of course, after COVID, really crucial. A double burden on communicable and non-communicable diseases, precision medicine, a very high priority topic, but also looking at health equity and gender and diversity, digitalization of health systems, e-health, and transdisciplinary research. So this actually is in the basket of research and innovation. But of course you can move forward if you don't look at the same time at the regulatory development of the regulatory environment. And I must say, over the 40 years that I have worked in Africa, a lot has progressed, and there are more and more kind of not only per country but also regional mechanisms that have been set up, such as the African Medicine Agency, that is kind of young but a very important step forward. Global system science and knowledge translation, as I mentioned already, is so important. In the methodology, what did we do? We talked, of course, to the European Commission, to the African Union Committee, And we said, well, in this limited time and limited budget, what are we going to do? We do a situation analysis, looking at all the literature published, gray literature in those areas, that's number one. But also we spend a lot of time on doing interviews with key informants, leaders in Europe, in Africa, in the health sector, and in the research, of course. Identify overarching lessons, success stories, and subsequent recommendations, policy implications for cooperation. We formulated then the recommendations related to the EU cooperation and bridging mechanism between RNI and development cooperation, because the mandate actually came from the research departments, but with very strong involvement from IMPAD. You all know IMPAD, the former DG8, the development agency. And I was so happy to see, because I have been in this sector for a long time, and in the old days, you had DG12 doing research, DG8 with a lot of programs in development, but there was not really a strong interaction, as we see in many countries. You see that at the level of countries as well, that the research community is doing this, and the policymakers don't know what the research is doing, and vice versa. And that is at, I think, the EU level, the AU level, the global levels, also in other countries and regions, and something that we have to address. Of course, between those four topics, health, green transition, capacity strengthening, research and innovation, there were all kind of cross-cutting issues, and we listed them there for information, because all of us make recommendations, and the recommendations of these four groups were overlapping, overarching, so then we put them together in actually chapter 5 of the report on joining these recommendations. Now, our policy brief, a draft outline here, focusing on research and innovation, epidemic preparedness. When I think a few years ago, health would probably not have been the number one, maybe number two. But then with COVID, suddenly, we were all in the same situation. It was different from the other epidemics. HIV, many parts of the world were involved. But like Ebola, only 3 countries in Africa, who cares about Ebola? So there was no global mobilization, no prioritization on some of the other infections. But then COVID came, and all of us, poor or rich countries, wherever you were in the world, we were all in that same situation. So epidemic preparedness, we realized this epidemic was predicted, and more will come. So now we realized more and more that we have to be prepared. So more interest for health and for the infections. Digital aspects, of course, strengthening of health research, and support to the genomic consortium. These were kind of highlights, not the only ones. As I said already, ethics and regulatory environments, and then bridging research and innovation and policy making. And I would even go further, because having been in this world, yes, to make policies, you need data. What you don't measure doesn't get done. But the other way, what you measure is not always getting done either, because you need you need decision makers, you need money, it's a kind of different architecture. So we need to do more, not only for the research, the translation. We have to, as researchers, we are not very good sometimes in communication. And that's why it's so important to have ARISE and to have these structures where the research data can be communicated, published, disseminated, very important. Then they have to be translated into policies, recommendations for the policy makers. And like a country where I live now, Kenya, I think is one of the countries who do very well in research, in policies, in guidelines, in strategies, sometimes translated into legislation. But the impact in the field on the Wananchi, on the citizens, and on the health systems is very low. We still, after all these years, the maternal mortality, which is one of my topics, has not gone down. It went down in the MDGs. We reduced, for the first time in history, we managed to reduce maternal mortality with 40%. We didn't reach the MDG, but first time in history, great. But now we are back to square one almost. It's like at the end of the MDGs, we turned the page, we went to a new framework, the SDGs, and we are forgetting some of the unfinished agendas of the old framework. So we should learn from that. What did we do well and how come that now? Because there are other priorities, of course. Now we have a new kind of hot topics. In the MDGs, we had 8 MDGs. Now we have the 17 SDGs. We forget about maternal health, child health, because now we have COVID, we have NCDs, mental health, and adolescent health. If your research proposal doesn't target these areas, you are in trouble. So it's kind of a different agenda. And it's good because there are priorities, there are topics that were not addressed during the MDGs. So this SDG agenda is much more comprehensive, etc. But we should learn from the past and not just jump into the new future, in the new system. So introduction very briefly, because I know time is running. Strengthening, one of our conclusions was really that strengthening of the health system is key. And that's not new. Those who were in 1978 in the Alma Ata, we said primary healthcare system is key, and the topic was health for all by the year 2000. Now the year 2000 is history, and now we say something else, but it's still about health for all by the year 2030 now. So we are not progressing enough. So the same concepts are there, primary healthcare and access to healthcare as human rights. But we have to do better, because we come, all of us, with vertical programs. I will fight for maternal mortality, antenatal care, family planning. The STD people are coming. Everyone comes to the health sector and builds vertical programs on the same systems, the 2 nurses, the 2 clinical officers who are there. This week they are trained in family planning, next week in vaccination, the other week something else. And then they go back to work and it's business as usual. So if we don't really consider, because primary health system is not something sexy. It's, the donors, the stakeholders, all of us, we run and we look for money to fund our own vertical programs, which is normal. But we all put it on top of a system that is not really functioning very well in many countries. So in our recommendation, we really call for input in the primary healthcare system. I'm going to skip a bit. Impact of the COVID-19 pandemic, of course, has influenced everything on human lives. Not only the virus, but also how do you cope with the pandemic. So we have learned a lot. And then we said now we have to strengthen mechanisms to be ready for the next pandemic. Question is, are we ready? Or have we forgotten already about COVID-19? And if the next pandemic comes, we are better prepared, I think. Just the fact that we can now communicate and have a meeting, hybrid, didn't exist really before. So every cloud has a silver lining, but I think we should not just turn the page again and forget the lessons from COVID to be shocked again when there is a new epidemic coming. The summary of the findings, again, I wrote them down here. More resilient health systems, public health systems that are endorsed by vertical programs. And we can learn a lot from HIV/AIDS, because initially it was a vertical program. It's still a bit a vertical program, but in many countries we have managed to really make sure that also the primary health care has been strengthened somehow. I remember in the early days when drugs were developed for ARVs, antiretroviral drugs, we were all thinking in Africa, we will never be able to afford this therapy for African citizens. It's too expensive, it will be done in the West. And we were wrong, because thanks to the kind of joint efforts and the vertical funding, now there are mechanisms that almost everywhere, you know, HIV has become a chronic disease, it's still there, but at least the systems are there, the diagnosis, the research is going on, and there we see a real impact. So I think we have to kind of look back at what have we done that we could take with us. My time, how many minutes? 2 minutes? 5, he says. So, so thematic health priorities, then equity is really, really important. I didn't talk enough about equity, actually. Because, and I think within, let me go to a good model, is EDCTP. I know that Martin has already, Michael Makanga has spoken. EDCTP was created 20 years ago to fight and to work around with Europe and Africa, HIV, malaria, tuberculosis. 10 years later, the neglected tropical diseases joined, and now we are in the global health EDCTP3. EDCTP is a good model, never perfect, but a good model that has strengthened research groups within Africa. And really a lot of capacity has been built. I think what we could do better, looking back at the EDCTP model still, is that, and we are going there, that also the African, not only the individuals, many Africans have, and Europeans, including myself, have had the opportunity to build their career thanks to EDCTP or other Horizon and FP program support, which is great. But what is needed is also institutional development. Because somebody who has gone abroad, has done PhD, great, applause, then you come back to what? So many remain abroad, somewhere else, because that's where you can develop your career. And I'm happy to see that more and more scientists, they come back to Africa because the institutions have been strengthened, but we should do more. And in terms of equity, we should do also more in kind of who can sign an EDCTP contract. In the past, it was only European institutions, right? Even if you have the PI in Africa, which is already a major advantage, but the contract was only signed by the European institution. Now we have in the new structure, South Africa can do that as well, and I think we will go, but we need to go a bit faster, that the institutions who are as good and have the capacity in Africa should be allowed also to be the primary, the contractant. We still have inequities, and not only EU and AU, but also other organizations. Those of you who have an NIH grant, for example, talking now not about NIH, but, and you get indirects. To your US partners, they go 50-60% of the grant goes to their indirects. What can we get in Africa? 8%. And now we have been going up to 11%, which is still, so there are inequities. And with our group, we focused a lot on inequity and also on diversity. Diversity in gender, but also language. Because the English-speaking African countries have, have been supported, I think, in, I'm not saying about Arise, but I'm talking about have a bit more chance to, and then French-speaking as well, but Portuguese-speaking countries are left a bit behind. So we have been working in this context also to make recommendations, to look at all kind of diversity and inequity, not only gender. Gender is a very important one, and I think now I hear the young men complaining that all the kind of the priorities, go to the women who work very hard, they grow fast, and that now they don't have a chance. I think we have to find a balance, but it was good that girls and women got these opportunities with scholarships, and Arise, of course, has also a very strong policy on that. So I'm going to just to skip, because you can read, there is also a whole section on what are the gaps, and I mentioned already some of them. Ethics and regulatory frameworks have to be more developed. It's ongoing, but And then we have a number of recommendations to the EU, to the AU, to strengthen also institutions, mechanisms. So you will read all this in the report. And I think it's also important, last but one slide, to highlight, as you all know, I think, it's not only about EDCTP, you all are all familiar with the Horizon programs, and there are some priorities in Horizon. Infectious diseases, surely, right? Global health cooperation is getting more and more interest, and within global health also the strengthening of the health systems and the health sector. Personalized medicine, there is a track within the EU. We call it, the program is called PERMED, Personalized Medicine. It's 3 years ongoing, some of you might be involved. And a lot of recommendations are coming out. There will be, end of this month, a workshop, and we will also formulate recommendations. As I said, chronic diseases and CDs are higher on the agenda, but I think we should not work in silos, because those of you who are in the health sector, we talk about infectious diseases and non-communicable diseases. But let me ask you, cancer is an infectious disease in 60% of the cancers. 60% of the cancers are, the origin is hepatitis B, hepatitis C, HIV, and other infections, HPV. Right? Cervix cancer, killer number 1 in many countries, HPV. So then we work on infections, non-infections, but we understand, of course, the frameworks, but we should also try to look at it from a global health perspective. What is priority number 1 in South Africa, in Africa? So many women are dying, and again, I come back to my own, the women's health, but look at cervix cancer, breast cancer, and maternal mortality, the 3 big killers of relatively young women. We know what to do. Research is there. Of course, we continue to do even genomic and more research, deep diving, but we know what to do. We have the mechanism, we have the prevention. Why is it not done? Why are still in Kenya, every year, 6,000 women dying of breast, another 5,000 of cervix, and more than 5,000 of preventable maternal death. So that's my big kind of call and my frustration, and I really call upon the research community. It's important to do good research. It's important to publish, to provide the evidence, but don't stop there. Try to work in your country with the ministries, with the parliaments. It is difficult, but as a parliamentarian, we managed years ago to set up within the Interparliamentary Union a group of researchers and parliamentarians on HIV/AIDS. And we made a handbook for parliamentarians because, just to end, if you are a politician in your country and you want to do good, HIV at that time, and you are going to run for elections talking about condoms, sex, MSM, you won't be re-elected, right? So that's topics. Now it's comprehensive sexuality education, very difficult, everything what has to do with these topics. So what we did, we made a handbook and reaching tools that based on public health, because public health is a very, very strong, every politician wants to come up with a health. Health is a very strong entry point. So if you don't hide it, but if you turn the messages, that you can also have that community working because they are the legislators. They control the budgets and they can be your advocates. So working with other constituency is so important. And altogether we have to do more that our research and the findings, that they also lead to changes and to improvement. And this is, I'm sorry that I didn't read everything, but the time doesn't allow when I go with the examples. This is the report that came out that has been presented on the summit with EU and EU ministries, and you can find it online if you want to read it in more detail. This is not only the health report, but also the green transition, capacity building, and the research and innovation priorities are in this report and are used by the policymakers and also in the new framework, because this is 21-24 for Horizon. Of course, the new Horizon is already being developed and is based on some of the recommendations in the report. So this is my last slide. I hope it was useful for you in this constituency. But of course, I'm here to address your questions. Thank you.
Thank you very much, Prof. And thank you for also keeping time. So in the interest of time, I request the panelists, starting with you, Craig, to come and give their talks. Please introduce your topic. I will not repeat the topic, so that in the interest of time, please.
Good morning. My English is not so good, because that forgive me if you will hear something you don't comprehend. My name is Euclides Sacomboio. I am from Angola, in Agostinho Neto University. I am lecturer in this university, and my project is blood group polymorphism and susceptibility in malaria. With this project, we want to identify distribution of blood group in the population in Angola, DAF, LEWI, KELI, KD, REH, 6L, trait, and others, and associate these blood groups with susceptibility and severity in malaria infection. And we want to assess a peer story of malaria to obtain more information about people which out malaria, because we are working with two groups, the group with disease and the group without disease, to compare and to understand if they have difference in result examines in these two groups. In the project, we start with, now we receive around 60% of the financiation of this project, because the project is only for 2 years. And I put here my groups, and we create one communitary labs. Firstly, we want to do the project in university, but in university we have a labs of university, and we think that it was important if we create a new labs out in university is a communitary lab. We create this lab is open. There is my team. I have 14 undergraduate students, 4 master student, and 2 PhD students in the project. What was the plan? We worked with 2 groups. Now we worked with the groups, is la patient groups, where we take samples, we analyze them, we follow the patients at the admission to the outcome. Could be diet, could be discharged in the hospital or another. And we do some exams. And now at March, the last year, for April of this year, we finished like 40% of the project. We worked with 1,120 patients. They are followed. Of this group, 315 are child, 700 are adults, men and women, and 105 are pregnant. We did this exam, biochemistry exam, hematologic exam, immunologic exam, urinary exam and genetic exam. Each patient did more than 40 exams, and with the sociodemographic data and vital signal, they have around 60 data for each patient. The impact results of this project at in this time. For the patients, I think that we change the medical assistance of in the patient in malaria patients, because that in Angola we don't have condition to do many exam in the patient. Patient did the PP is a pesquisa of plasmode, and they receive one medication. In the project, we did many exam and put this exam in the prontuary of the patients, and the medical could attend this patient with more information about the patient, because that we reduce the mortality in this group, because the two studies we did before this start, where we did it, the mortality was around 10%. In this project, it was 3.9%. We reduced so much the mortality in this group when we put more information about the condition of the patient. On the second impact, I think, was for the transformation of the student. In Angola, we don't have many opportunity to have a scholarship. We give scholarship for the student. We put the student in a scientific project. We train them. In this time, we have published some result of our project, and our student could have publication for next point of their formation, like undergraduate could go to master, or master could go to doctoral program. They have more opportunity because they work with us in this project. And in this project, we worked with medical groups, biomedical groups, nurse groups, nutritionist, physiologist, psychologist, and TA specialist. Another impact we think this project give is medical assistance, because we change it. And we think we will change again, because now we are doing analysis. Maybe we can find like tendency of bad outcomes in the patient, and with this information we can help the better assistance for the patient with malaria. Another impact we think this project will give is because we are working with intelligence, artificial intelligence, and we are put all our data to see the associate condition could be better, could provide information like for complication or possibility for die, and maybe we can help the Minister of Health to create mechanism to guidelines to orient the medical group when they will attend patients with malaria. Product of this project. The first one is the community lab. Community lab is our labs, is lab from the arrays, and in this lab we are doing our projects, but the lab attend the community. And the price of the exam is very low. to have idea, for one pregnancy did all exam in Angola, he need to spend more than $100. And in our lab is around $80 for this all exam. Because we have equipment and we can use this equipment for give the result for the human pregnant.
You have 1 minute to come.
Scientific results. We published 2 papers with this work, and we believe that in final of this year we can publish more 4 papers because we have so much data. We need to sit to analyze this data and publish more results. Expression is to work with the control groups, and we saw that in blood group HBO, the adults, the group EB is around 3.47%. In child, 35%. I think that the child AB don't become adults. We don't know why, but maybe could be the next project we will do to understand what is happening in the AB groups. They have the number is very high in the child, but in adult is very very small. We can do that with this project and with this financiation. We don't just arise, we also arrived in our community to make a difference. I need to say thank you in English, but I need to say obrigado in Portuguese. I need to say Topandula, Tasakidila, Ndasakidila, Tutondele. As the language of Angola, we have 9. I put only I know. And I need to say it for African Union, for European Union, Academy of Science, my university, and Institute of Pasteur. Thank you.
Thank you so much, Dr. Euclides. Now you can have Dr. To. Please introduce yourself and the topic for the interest of time, and use your 10 minutes.
Bonjour à tout le monde. Good morning. I'm Yassem Toé from Burkina Faso at the National Center for Research and Training on Malaria. I'm also working at the university as a senior lecturer. I'm more than lucky to be here because I joined the IRS program 6 months ago. Yeah. And then great thanks to the African Academy of Sciences, and then to give me this new opportunity to work on one of the most important topics for me. Because I did my PhD in malaria vectors. I switched from malaria vector to dengue vector many years ago because then my country was needing some experts on working on dengue vectors. Then my project is about ecology, behavior of the insecticide resistance in the Aedes mosquitoes, the primary vector for dengue, chikungunya, yellow fever, and Zika. This map shows the global situation of the dengue in 2023. As you know, Asia and Latin America is known as the epidemic part, then country of the dengue. What happened in this year with the global warming, with the climate change, and also with the growing of the urbanization, dengue is becoming a problem in Africa. You can see here in West Africa and in East Africa, the number of dengue cases is increasing. Just have a look on the situation of Burkina Faso but in 2023, we record more than 150,000 dengue cases with more than 700 deaths. That is quite really, that's not good for the country. We also observe some yellow fever cases and also some also, but some, we are yellow fever and also by chikungunya, by disease in Burkina Faso. It's clear that but the number of the dengue is really underestimated. And then in Burkina Faso, we are moving from the tropical neglected disease to disease with epidemic potential. What's about the vectors? But the vector of dengue, Zika, and chikungunya, but in Africa, is the tiger mosquitoes, so-called Albopictus. And the second vector is Aedes aegypti with two subspecies, Aedes formosus and aegypti. And then for control the dengue vectors, there are four main strategies. The first one is the live resource management. The second one is genetical control. And the third one is the biological control. The one used during outbreak is the use of the insecticide as just fogging or indoor residual breath spraying. But the problem is that insecticide resistance is becoming a great problem in Burkina Faso and also in other parts of Africa. And then we published that paper to show that Aedes from Burkina Faso are resistant to all insecticide but classes. My ARES project, which aim to characterize the extent of the insecticide resistance and the underlying mechanisms in Aedes aegypti, and assess how this can impact the behavior and the ecology. I have three main objectives. The first one is to assess the partial, and then the first one is to assess the evolution of the insecticide resistance and the underlying mechanisms in Burkina Faso and also in West African countries. And then the second one is to determine and quantify the fitness costs associated to DDT resistance. And then the third one is then to determine the host-seeking behavior and how then the resistance is impacting this behavior. And then to achieve this goal, this objective, first of all, we plan to assess the level of the insecticide resistance in all insecticides you can have on the market used in public health. You plan to do it in the urban and the peri-urban zone in Burkina Faso. And also, you plan and then to target some gene involved in the insecticide body resistance. And also, you plan to do the RNA sequencing and then to identify new marker and new gene involved in the insecticide resistance. And also, you plan and then to select and then the resistance strain and then to access live threat parameter which can affect the insecticide resistance. And then also, you plan as activities to do the human library caching to assess the biting behavior. Also, and then the biting behavior. The most important thing here, we want also and then to see if the temperature, the humidity of the light but intensity can also affect this one. And also, you want to screen for all the resistance marker in the Aedes mosquitoes in Africa and also in Burkina Faso. Alors, the key outcome of my project, first thing, we plan to establish insecticides by profile to common insecticides used in public health for IDS and control. And then we want to catalog all kinds of insecticides by resistance and the distribution over time in other countries, also in Burkina Faso, in South Africa. And also, after identifying some new resistance markers, you plan to develop a low and simple method and then to screen for this mutation. The impact of that one will be to improve the insecticide resistance plan, and this one will help to improve the insecticide by resistance, the management in Africa, and also to maintain the effectiveness of the control strategy based on the insecticide resistance tool. And also, you plan to select and establish the insecticide strain for Africa that could be used in all parts of the country. That will facilitate the evaluation of the insecticide control tool. The next one here, the next one here now is to update the biting behavior, because in the literature review, Aedes mosquitoes is known as day-biting mosquitoes. Our preliminary data show that Aedes mosquitoes can bite both indoor and outdoor in the day or also in the night. This will help us to update our control strategy. This is also the slide to make the advocacy, because I will look at what dengue, chikungunya are emerging or re-emerging in many parts of the Africa. I think we need to increase the awareness of policymakers to more support research on dengue and arbovirus vectors. I think for the coming year, dengue will be the primary problem in Africa. And then to finish, I just want to thank all my collaborators and also all the young team I'm going to build in Burkina Faso to fight against Aedes mosquitoes. Thanks so much for your attention.
Thank you so much, Dr. To, for that nice presentation. Our next presentation is virtual, also from Burkina Faso, by Dr. Etienne Bilgo. Is he ready to start? Okay, thank you.
Good morning.
Good morning, Doctor. You can continue.
Yes, please. Can you see my slide?
Not yet, Doctor.
Hola.
Not yet, Dr. Bilgo.
Not yet.
Not yet.
I don't know why.
Can you please try presentation mode?
Yes, I'm on presentation mode.
Screen share. Dr. Bilgo, can you share your screen? Maybe that's what is lacking.
Okay, I think now I'm okay. Can you see my slide now?
Yes, we can. Just put it in presentation mode, please.
Okay.
Thank
Thank you very much. Can I start?
Yes, please. You can start now.
Okay, thank you really very much. And first of all, I want to say thank you very much to the ERISE team, Dr. Obed, Roland, Boni, everyone, and my fellow colleagues from ERISE. And I would like to share some slides on my ERISE fellowship. And I'm really sorry to not be able to join you because I'm in a trip in Malaysia related to my ERISE program as well. So in terms of my presentation, this is mostly the outline of my presentation. I wanted to talk a little bit about the justification of my project. And my project is really based on microbial biotechnologies. And I will show some data and publication that we published so far on fungal-based strategies using metarhizium, using microsporidia, and also bacterial-based strategies using Chromobacterium serratia as well. And also I will end with the use of Wolbachia for dengue and malaria control. So I will not spend a lot of time on the justification because Toé just talk about the burden of dengue in Burkina, but also we have malaria, which is the first public health problem. But what I want to emphasize here, you have to know that this disease really undermining the development of the continent. And the main problem here is the failure of vector control tools that we use to work with to control the disease. And we need new tools in order to continue to gain our battles against malaria and dengue. And this is one of the purpose of my ERISE project. So let's talk a little bit about how to find new solution when it came to control vector-borne disease. So here in the screen, you can see the systemic component when it comes to control vector-borne disease. You have the parasite, for example, for malaria, this is the parasite here on the left, or you have the vector, and also the vector is the agent which is transmitting the parasite or the virus for dengue cases, for example. Then you have human here, and you have the environment. If you want to control sustainably vector-borne disease, you need to come with tools that can bring the links between these four systemic components. And if you want to come with a strategy which is going to be really powerful, you need to associate different strategies. We can, at the same time, break the links between the strategies. So in my lab, we are really focusing on the use of microbe as human insects also facing infectious diseases like bacteria, like fungi. And, let's do a little bit of science history. And what you can see here, generally people are thinking that Louis Pasteur or Robert Hooke are the father of modern microbiology. But before this great researcher, there is an entomologist called Agostino Bassi, who is the first person in the history showing that a living organism can be killed by another living organism that you cannot see. And this is the discovery of the germ theory. Since then, people are trying to use fungi, bacteria, viruses in order to control pests. And this is mainly in agriculture. And you can see here, for example, in the US, in 2017, we have around 300 and so patents of formulations to use microbes to control insects in agriculture. So I'm based in Burkina Faso, and our lab is a medical and parasitology lab, and it's a joint lab from IRSS, which is from the Minister for Research, and San Mirage, which belongs to the Minister of Health. That means we are working with the two ministers together in order to find new tools. So since the launch of my ARISE project, I'm trying to build a team of young researchers, and this is our last lab meeting in order to talk about the different development in the project. So what we have in terms of research questions, it's mainly around microbes, to understand how they are behaving with their host in order to find new solutions to control vector-borne diseases. And one thing that I want really to emphasize is to show that one of my main goals is to train and mentor a lot of young generation African scientists in order to control vector-borne diseases. So in terms of, we started to generate some data, and in terms of using fungi, we have recently show that the specificity of the fungi to control mosquitoes is at the cuticular level. It looks like the fungi that we are isolated to control mosquitoes, they really know their true host. They are testing the skin of the mosquitoes. If it's the right host, that means that they can start the infection process. And also, with one of my PhD students, we have shown that using fungi to control mosquitoes, this can be worked synergistically with insecticide. That means that you can work together. We can make formulation with fungi and insecticide. And in this case, we can really sustainable control malaria or dengue vector. And this was published this year in Malaria Journal and in the Wellcome Open Research. So another project that we are currently carrying out in our ARISE project is about using Microsporidia. This is another fungi that can block the development of malaria parasite within mosquitoes. And we are starting this project, and we have two PhD students and another master student. We just defended master last December. And we also collaborating with some students from West Africa. And here, this is a publication from one of my students in Niger that I recently mentor for his master. And we first identified Microsporidia in Anopheles mosquitoes in Niger. Then we have another strategy, which is to use bacterium. I was talking about fungi, but now we are talking about bacteria. We have currently developing bacteria that we isolate in new strains of bacteria, which is really pathogenic for mosquitoes, but not pathogenic for humans. And we think that we can use these bacteria as well to control mosquitoes.
You have 2 minutes, please.
Okay. Then we have another strategy, which is to use Serratia. Serratia here is another bacterium that we can use to block the development of parasite within mosquitoes. In this case, we are making mosquitoes not able to transmit the disease. And this is one of my PhD students, fully supported by ARISE, and she is presenting a poster during the ARISE meeting in Tunisia currently. I'm really inviting you to visit a poster. So the last strategy that I wanted really to talk about is about the Wolbachia project. So Wolbachia is a really interesting bacteria. For example, if a male of mosquitoes has Wolbachia, and if a mate with a female without Wolbachia, that means we don't have eggs here. And for example, Wolbachia looks like a system of microbial vaccination of mosquitoes. When a mosquito has Wolbachia, it cannot transmit any disease. It cannot transmit dengue, it cannot transmit malaria, for example. And this is really interesting. And so far, we think that we are currently running one of the most advanced Wolbachia program in Africa, because we already established line and also starting to generate lab data. And we have shown that when a male of a mosquito having Wolbachia mating with female, we don't have any offspring. That means that we are making mosquitoes sterile. So if we don't have next generation of mosquitoes, that means we don't have mosquito to transmit the disease. If we don't have mosquito to transmit the disease, that means we don't have vector and so on. We don't have the disease. So currently I am in Malaysia with Oda Nipad from the African Union in order to see how we can develop this program in Burkina Faso in order to control dengue. And this is a picture of our Minister of Research and Minister of Environment releasing mosquito with Wolbachia. We wanted really to learn from Malaysia, which is really advanced in this kind of program using Wolbachia to control dengue. And we really hope that in the coming month, we will be able to start some field works with Wolbachia. So I have Estelle here in the room there. She is presenting also some work on Wolbachia in malaria mosquitoes, and I really invite you to talk with her and see what she's doing on Wolbachia with Anopheles. This is also one of my students. She is currently at Institut Pasteur in Paris to work how to study the investigation between Wolbachia and microbiome within Aedes mosquitoes. She received at the start of a RISE program with me a first prize with IRD on my thesis in 180 seconds. And she's doing this booklet in order to disseminate what she's trying to do on this RISE project. So I would like to conclude to saying that in this RISE project, we are really trying to put in place a research, but also a development project in order to come with innovative tools that we can use to support our current vector control tools. And also we have also a big capacity training program during this RISE project. I was assigned to have like 3 PhD and 4 master, but currently we have around 6 PhD and more than 8 master, and we are training more than 45 professionals from National Malaria Control Program officers. So I would like to say thank you to my collaborators, and thank you so much once again to ARISE and to the African Union, to the European Union for this really great opportunity that you are giving to us in order to build our career for the development of science in the world, and specifically for the development of the science in Africa. Thank you so much, and look forward to have your question and comment. Thank you.
Thank you, Dr. Bilgo. Please stick around for the question and session that will come after the last presenter. The next presentation is also virtual on improving the diagnosis and surveillance of emerging arboviruses by Dr. Ngu Ambanda from Cameroon. Doctor, are you available for the talk?
Hello? Can you hear me?
Yes, we can hear you. Please put your presentation on and then let's proceed. Thank you.
Actually, it's on share. Are you seeing my presentation?
Not yet. Yes, that's okay. Thank you.
All right, thank you very much. Good morning to everyone, and apologies on behalf of the organizers for not being there in person. I just want to say it's a pleasure to be part of the ARISE family. I just joined 6 months ago, like you said, and I'm so excited about the whole prospect of the ARISE Fellowship Program. Okay, so my name is Dr. Ngunjay Abanda. I'm a lead scientist at Sanju Pasteur du Cameroon. I work mostly on the arbovirology laboratory. So my institution is found predominantly in Yaoundé, Cameroon, but we have like 3 campuses across Cameroon. We are a public health and research institution in Cameroon, and we're also a technical entity of the Public Health Ministry of Public Health in Cameroon. We were a national and reference laboratory for high-risk pathogens, namely viruses, fungi, and parasites. So we were created in 1959, and as I remember the Pasteur Network, just like Institute Pasteur Tunis. And we have 4 missions as medical analysis, predominantly clinical diagnosis. We have a public health mission, and we have a research, and we have a training program as well. So each year we receive close to 20 to 30 masters and PhD students, which are enrolled into our various public health and research programs. And this enables them to be able to complete their masters and PhD research work. We have around 280 personnel across our different campuses, predominantly lab technicians, clinical microbiology research scientists, students, and administrators. So where am I exactly in the whole of this web of things? So I'm the lead scientist of the arbovirology laboratory, and which is part of the virology service. And there are about 7 laboratories within the virology service. So what is arboviruses? So basically, I guess most of the earlier speakers have hinted on what arboviruses are. They just go to refresh everyone, get everyone on the same page on what these viruses are. So these are viruses that are transmitted by mosquitoes or arthropods, mostly mosquitoes or ticks or flies. So what we know is the yellow fever, the dengue, the chikungunya, the West Nile. Those are the predominant ones we really know. Why are we interested in these arboviruses? Our environment is changing, and it's creating conditions that are conducive for mosquitoes and the viruses they transmit. We know the climatic changes, we know the unplanned urbanization, the tires are good sites for the mosquitoes, and they transmit. And if we observe over the last 20 years, there's been a tremendous increase in arbovirus cases. We look at just dengue cases. The number of cases of dengue have increased by tenfold, from 500,000 in the 2000s to about 5 million in 2019. There have been numerous outbreaks in Africa: Burkina Faso, Ivory Coast, Senegal, Kenya, and more recently, Chad, Ivory Coast, and Burkina Faso had a huge outbreak of dengue. Chikungunya has also been part of the whole outbreak scenario. As of 2020, over 97 chikungunya outbreaks have been reported across 45 countries, with some countries like Chad registering their first ever outbreak of chikungunya. And recently, there was an outbreak of chikungunya in Senegal. Yellow fever also has been part of the whole pack. There have been numerous outbreaks of yellow fever, notably in Brazil, in Angola, in Democratic Republic of Congo. But last year, we had a huge outbreak of yellow fever across several African countries. The number of cases skyrocketed. And what we see is that these mosquito transmitted viruses are touted to be the next big pandemic. So the huge question is, what are we doing about this public health threat? At the level of WHO, they're already mobilizing to see, okay, what can we put in place to make sure that there's coordinated effort to reduce the risk and challenges posed by these viruses. Within the Pasteur Network, which is part of my institution is part of, there's also a serious scientific orientation and consultation about what can we do about these mosquito transmitted pathogens. So at the level of my institutions, we have identified some pathogens of interest: yellow fever, dengue, West Nile, chikungunya, Rift Valley fever, criminal hemorrhagic fever, and Zika. And our actions are along these 4 lines. First, how can we monitor real time and expect any risk of arbovirus epidemics or pandemics across the country? How can we strengthen vector control or develop new approaches towards vector control to monitor and limit spread of arboviruses? You heard so much from the previous speakers about vector control. Thirdly, how can we accelerate the development of new diagnostics, treatment, and vaccines? And how can we build coalitions with partners locally to raise awareness and improve the control of arboviral diseases? My ARISE project is actually interwoven within these 4 key priorities areas. So the first question I'm addressing through my ARISE program is, where have arboviral outbreaks likely to occur in Cameroon? We have a biobank of close to 2,000 samples collected since 2010 to present. What we want to do, we want to search, where have there been any arboviral infection across Cameroon? The samples come from all regions of Cameroon, and if you look at the map on the right, the age range goes from 0 to about 6 years of age. So we're using the Luminex assay to test these samples for the presence of antibodies to these arboviral infections. We want to know the areas that are likely to have been exposed to arboviruses. It could be areas in close proximity to forests. It could be urban areas as well. We want to know where these outbreaks have occurred. But you have to bear in mind that there's no surveillance system for most of these mosquito-transmitted viruses. So we are actually basically fishing for information to guide the Ministry of Public Health on how to go about setting up a surveillance system. Now that we know where the arboviral infections are likely to occur, how can we put in place a system that actually monitors in real time any arboviral threat? If we look at our current public health surveillance system, it's based on the fact that it relies on the patient developing symptoms, reporting to health facilities, and the health facility being able to detect that infection that's having the presence of the kid. The personnel is trained to be able to detect, clinically detect the infection suspected, and have the testing kit to be able to guide in that testing process. Unfortunately, the way our healthcare system is structured is most of the patients that have been exposed to arboviral infections tend to have mild or asymptomatic, so very mild symptoms, and they won't go to the health facility, they will self-treat. Also, at the level of the health facility, most of the medical practitioners are now aware of arboviral infections like dengue, chikungunya, everything. They are more oriented towards malaria, and there are no testing kits available. So how do you set up a surveillance system within the mix in the current system? An alternative route which we use is the entomological surveillance. We know for sure these viruses are transmitted by mosquitoes. So we could also monitor mosquitoes to see for the presence of these viruses. That would be an easy way because mosquitoes, you don't need any ethical approval for mosquitoes. It's easy and straightforward. But the challenge with mosquito is the low virus carriage rate. And you need trained personnel to be able to collect the mosquito, dissect the mosquito, and test the mosquitoes. So what are we proposing? So we have put in place what we call a honey-baited mosquito trap system. And this system, we're looking at six health districts in Cameroon. So what is this honey-baited mosquito trap system? So this is your typical mosquito trap. The trap is designed to lure mosquitoes into the trap with a lot of attractants to lure the mosquito in. And what we are doing now is putting in an FTA card. The FTA card has the possibility of preserving any nucleic
You have 2 minutes, doctor. 2 minutes, please.
And we are coating this FTA card with honey. And this is pretty much the setup. The idea is, once the mosquitoes are lured into this trap, they will feed on the honey or sugar on the FTA card. And in the process of doing that, they will inject their saliva on the FTA card. This FTA card can now then be extracted and tested by PCR. So in this way, we don't have to collect mosquitoes. The FTA card preserves the genetic material. We don't need a cold chain. So it's an easy way to set up within communities and test for the presence of any viruses. So we have set up this system in about 6 health districts. We'll at the same time also be evaluating the system by test screening patients for any arboviral infection, see how effective is the system in capturing what is being transmitted to patients. Behind this also, we have a test study. We need to develop a diagnostic assays. So in addition to the patient we are screening, we'll be collecting follow-up studies to collect samples from this patient. And through this patient, we'll be able to have a good viral bank where we can test for different body fluids for the presence of the virus, evaluate new diagnostic kits like molecular kits and superoriginal kits using this viral bank of samples. One really good thing about this initiative has been the ability to build capacity. At my institution, we have paused and we thought about how best can we build capacity within Santé Pasteur, which is not like a formal university setup. We are more research and public health oriented. So what we have done is we have set up a committee, a technical advisory committee to guide in this process. So we are forming collaborations with universities and set up training programs. And for people to enroll into this program, they have to actually apply to be enrolled into this program. So the idea is how can we make sure that the students get the best of training through the ARISE program, and they are also retained by past. So we are not just looking at the master's and the PhD level, we are also looking at the postdoctoral and early career scientist level, giving opportunities for a lot of people to be able to retain while they complete their PhD. So I just want to thank a lot of people who have been participating and helping out with this work. Especially thanks to my domestic collaborators that have been very helpful, and also to our foreign collaborators that have been very helpful in this process. I just want to acknowledge the flagship ARISE program has been really great in giving that extra funding. We have also been fortunate to have extra funding from the CREED Network, the Cambridge Arboreal Fund, and the Grand Challenge Canada project. So some of these aspects, what we could actually do is really thanks to this additional funding that we got from, but ARISE was really there to initiate all of this. So we're really grateful to the European Union, the African Academy of Science, and the African Union for putting in place this catalyst that's led to more funding coming in. Thank you very much.
Thank you so much, Dr. Banda. Please stick around for the question and answer session after the last presenter. For now, I want to welcome Dr. Rati Gaye from Senegal to give us his talk. Please introduce your topic and where you come from.
Thank you. Good morning, everybody. I'm Lati from Institut Pasteur, Dakar. And I'm going to give you my talk about assessing the functional impact of genetic diversity on the malaria vaccine candidates PFRH5. So, as you all know, there's no need to say that malaria is bad. We all know that. But I want to just bring some level of optimism on the table by saying that although malaria is bad, it is still treatable but also preventable. So one of such strategies for preventing malaria is the use of vaccines. So on these slides, I'm showing the current malaria vaccine land map as of July 2023. So I would like you to focus on the red rectangle, where we can see that at that time we had 153 trials that was registered for malaria. Of these, 89 was like registered antigens for vaccines. But the challenge was that out of all these strategies that were being tried, only 2 antigens managed to make their way all the way to the phase 3 clinical trials and got approved by the WHO for use in endemic settings. And these were the RTSS and the R21, which most of you might be familiar with. And these ones target the liver stage of the parasites. But the issue with these vaccines, although they prevent malaria, the stage they are targeting is not responsible for the clinical stage, the clinical phase of the disease, which is the blast stage, which calls for the need to develop maybe a next generation of malaria vaccine which is going to protect against the clinical diseases. And talking about this, one of the main challenges of this is genetic diversity, which was not taken into consideration in the earlier phases. As living beings, we all strive to survive, and the parasite dies the same. What has been used historically for malaria vaccine development was to use antigens from culture-adapted laboratory lines, which have been maintained in culture for so long that they've lost all contact with the environment and were not diverse enough to represent what's happening in the field. And as you can see on the bottom of the slide, what is happening in the field is totally different because these parasites are challenged by environmental, therapeutic, and preventive techniques so that they adapt to try to move around and escape these strategies. So some of the key questions I asked during this ARISE proposal development was, does genetic diversity in vaccine candidate antigens functionally impact efficacy? And to answer this question, we are using a unique lens in the dynamic of the field, trying to evaluate the natural circulating complex parasites in the field. And also the second question was, can we adapt vaccine formulations to alleles that will maximally protect against the most diverse strains? And through this, we are using the research and development clinical approaches to answer this question. So in this slide, we have an outline of our progress and what we are aiming to do. We know the challenge, which is genetic diversity. And the approach we are using is to do genomic surveillance to know exactly how diverse the parasites circulating in the field are, and finally, to use functional assays to match genotype, phenotype, to answer complex questions. So with regard to my project, I'm focusing on the malaria blood antigen complex, which is the PCRCR complex, which is a pentameric complex composed of PTRAMP, CSS, RIPA, SIRPA, and RH5. All the 4 teters, the last one, which is RH5, to engage the Bacillin receptor on the red blood cell and enable invasion. But all of these antigens are essential for parasites. So if you knock out one or block one, the parasite will not be able to engage the red blood cells and invade it. And we thought that until recently that all these antigens were conserved, meaning that they were not much diverse. So when I came back to Senegal after my PhD to do my postdoc, I found that there was COVID ongoing, and I had to find ways to get busy. So I used the data that was available there to analyze the RH5 antigen, and realized that out of 156 isolates analyzed, I found 90 single nucleotide polymorphisms that were predicted to have different impact on the structure of the antigen, but also predicted to maybe cause immune evasion. So the question I wanted to answer was how this affected. And the same thing also was done with one of the PhD students in the program using the SIRPA, and we identify also mutations on this antigen that are also predicted to either alter the structure of the antigen, interaction of the antigen with SIRPA, or binding near antibody epitopes, which might be challenging. Similarly, the same thing was happening with another complex member, which is RIPA, which is also diverse. But as we were doing this, at the time we were doing this study, there were no available structure of RIPA, which is just being released, so we could not really predict the impact of this mutation. But this is a work in progress. So what I'm currently doing is now looking at the genetic diversity in the field. How does that impact the efficacy of vaccine-induced antibodies? So for this study, I'm using antibodies that were generated from phase 1 clinical trials using a viral vector regimen of the chimpanzee adenovirus virus, and then with the MVA, where we have the RH5 encoded. And PBMCs were drawn from these trial volunteers and stored for later use. Finally, what we did was we isolated monoclonal memory B cells from these vaccinees and amplify the variable heavy and light chains from these single cell sorted monoclonal memory B cells from the volunteers using antigen specific probes, which are the RH5 bioattenuated probes. So finally, what we did was we cloned these variable heavy and light chains into IgG1 vectors, which are coding the human FC region, and expressed this using the EXP293 cells, and purified the antibodies using the ACTA purification method. And these antibodies were then used to perform ex vivo analysis in the field where parasites were from individuals who were suffering from malaria. And here are some of our data that we collected from this study. We can see that these antibodies block parasites invasion no matter how diverse the population is, which is a good news, because this matches also what has been shown with laboratory lines, which is a very good news. And what we also realized is that one of the lab lines that we used was able to escape immunity in one of the most important antibodies, and this is the FVO you are seeing here, which is not inhibitory. And our investigation showed that because of this isolate has a single mutation polymorphism on the position 197, where the serine amino acid is replaced by tyrosine amino acid. So next, what we wanted to see was, okay, some of the antibodies are not inhibitory, but what happened if you combine them together? So we combine antibodies that were less potent together to see how well they perform. And one of the antibodies, which is the R11, is potentiating the impact of, or the inhibitory potential of other antibodies. And we can see that we have kind of a uniform level of inhibition of these antibodies, but there were one isolate that was showing antagonistic relationship across all combinations. And this isolate is being pursued in a complementary experiment to see exactly what is happening in terms of genotype-phenotype relationship. So the next thing also we did was, okay, these isolates are susceptible to parasites, to inhibition, but how diverse are they in terms of genetic polymorphisms? And we identified 15 polymorphisms, and of these, we have three different groups. Some that were enhancing binding of RH5 to the bacillin receptor, some what was enhancing the RH5 binding to SIRPA, and some that were altering the structure of the RH5. And this is leading to the next step of our proposal, which is to now confirm this genotype-phenotype relationship we observe or we are predicting using the CRISPR-Cas9 technology, where these mutations will be cloned into parasite lines and assessed functionally to see whether we will infer, confirm or reject this hypothesis of impact of genetic variation. So has an impact for the AU-EU strategical plan. This project is innovative and will contribute to technology of transfer through adoption of state-of-the-art technology, develop and strengthen Africa-based research and innovation, but also contribute to capacity building and also public health through the contribution of providing highly effective malaria vaccine strategies. With this, I would like to end and then thanks my collaborators and the PhDs and master students that were involved in this program, and also the AU and the EU for the funding, and Institute Pasteur for hosting me. Thank you very much.
Thank you so much, Dr. Ratti, and thank you for keeping time. With this, I want to introduce Dr. Protas from Cameroon. Please introduce your topic and go with the momentum of keeping time. Thank you.
Thank you. Okay, thanks for having me. I'm Protas Aritakang from the Institute of Medical Research and Medicinal Plant Studies, Yaoundé, Cameroon. And in keeping with malaria, from vector control through diagnostics, I think we are now on drug discovery, natural products based. I'm a pharmacognosis with background in biochemistry and a keen interest in pharmaceutical medicine. So I would, with your permission, that is my ARISE project title. I won't read it, but with your permission, we'll leave the scientific space and we'll come down to the public space. So I have requested innovative lead discovery strategies for malaria therapy, and I think with this we'll be going through. So we'll look at the preliminary steps that we'll carry on to attain the first specific objective. So we'll be looking at the synergistic interactions of plant extracts in polyherbas which are multi-plant components, which are anti-malarial, and we'll look at how this synergism improves their therapeutic selectivity. So with this, I think we'll ask a few questions in mind: why plant combination and in what ratio they are used, because this will answer the question. We understand the WHO has given a strategy on the use of plants, but commonly, because of the lack of access to new medications, a lot of people in endemic countries are using plants, but we wonder how they are using it. And we'll look at what solvent systems are good for these plants. We'll also ask the question of what is the role of each of these plants, why are they in combination, and what is the role? And of course, we'll look at the bigger picture. We know of recent the African Medicines Agency was created. How does this contribute to developing the local pharmaceutical industry? Of course, we won't go back to the demographics of malaria, but we understand that the emerging resistance in Plasmodium strains to current drugs or drug molecules obliges us to look at different approaches towards the development of drugs. And of course, going back, we realize that the rate of withdrawal of synthetic drugs has been more than what has happened to natural source molecules, starting from the days of chloroquine and coming back to present to artemisinin. So of course, we know that plants represent a significant role in this pharmaceutical industry, but we ask the question now, with this increasing resistance, what happens? So in the era of combination therapies, we think that polyherbas or multi-component plants are an asset because these components have synergistic therapeutic effects, and that's what we'll be looking at. And we think that when we oblige to look at the various stages of the malaria parasite cycle, despite the structural diversity of these plants, we can use new technologies, which is the in thing now, such as mass spec combined to HPLC and NMR, and combine it with new high throughput screening technologies, getting this together so that we can look at new ways of sourcing molecules for development. So we'll just look at, we've worked with just three. Here I'm just going to show you the three examples of three of the polyherbas that we work with using in vitro antiplasmodial cybergreen-based techniques, and we use that on just single and multiple do. So we look at interaction studies. So on this, we were looking at both aqueous and ethanol extracts of the plants. And in red, you see that for the first polyherbal, both showed synergism, and the first plant had quite a lot of, polyherbal had quite a lot of plants, which were up to 6. And when we go to the next, we realize that the next two, one, the solvent system is aqueous, which is good, giving a fold increase of about 8. And the third is the ethanol extraction system, giving a fold increase of up to 39. And beneath, we realize that when we use these extracts, we can now see the combination ratio of the various plants. And this is based on their potency. So with this, we can now advise those who are using, for instance, those who are using plants on what combination ratio they can use, which is a direct system, so that they can optimize the therapeutic effect. But now to explain how is this synergism going forward with the project, how do you understand this synergism? We'll look at both the pharmacokinetic synergism and we'll look at the pharmacodynamic. What does the body do to it? And in this, we'll be focusing on the facilitation of the absorption, distribution, metabolism, and extraction of the plant extracts. And of course, to understand this, we'll have to go back to our technologies so that we can do an easy identification of what confers this activity, what are the quantitative and qualitative characterization of all what is contained in the plants. And when we look at the pharmacodynamic synergism, we're intending to study the combined therapeutic effects. And this brings us to our stage specificity when we look at different sexual blood stages, and we look at the combined effects. And by combining these two, it will be an easier method for us to discover leads that can be the downstream chemical analysis we can exploit for drug discovery. So by improving this therapeutic selectivity, synergistic activities of constituent plants or polyherbals will enable them to be an asset. Because when we look at those combinations and we go through the technologies and identify and understand what metabolites they contain, we can then use this as a template for further drug discovery. And of course, using the methods that we've just described already we have started remote working with our partners in Italy and France for the metabolomic studies. We need robust computers for data analysis. We have had that already, but we need to go on site because we don't have the mass specs and the NMR. That's why we are collaborating. But thanks to ARISE, we are setting up a high throughput screening platform. We've procured equipment worth 120,000 euro. We are just waiting delivery, which will start from the month of July. I hope that when this is installed, we'll be able to showcase, because experimental validation is of utmost importance in drug discovery in order to go forward to development. And regarding capacity building in the project, I have a team of 12 members, multidisciplinary. We have 4 PhDs, 2 funded by ARISE, the other 2 profiting from ARISE resources, which we are grateful. We have for the moment 2 ARISE masters who are fully funded by ARISE. And in the process of starting this project, my institute, we didn't have a grants management office. When we did the due diligence, we did some kind of advocacy, and we were happy that the board created a sub-directorate, which is now strengthening the research management capacity. And in that right, I was privileged to head that department. So we are seeing how we can facilitate project management for the rest of grant holders. We'll look now at the big picture of the pharmaceutical industry, how do plants contribute to that? Of course, they can serve as a direct source of therapeutic agents. So far now in our library from the ARISE project, we have more than 40 compounds that we've isolated. But like we said earlier, in the production of phytomedicines and standardization, we are struggling to get a PhD student to test this on field isolates. But before doing that, they will use our platform to validate the potency before test that on field isolates. They can also act as source of raw material for development of complex semi-synthetic drugs, which is, we have another PhD student who is going to do now from this generative chemistry, trying to modify these molecules so that we can see how they can become more active. And of course, we'll test that on and validate on on our platform. And they can also serve as prototypes for design of lead molecules. And of course, with the molecules we have a partner in France. We are trying to introduce molecular networking, which is a process of using all these technologies for easy identification of this. And lastly, as taxonomic markers, this will help those who are using the crude extracts so that we can make sure you are using the appropriate plant. I think with this, I would want to thank ARISE, AES European Union, and all the various partners we are working with at the moment, and say the future is bright, and hope that we'll have the opportunity to showcase more what we are doing at the appropriate time. Thank you very much.
Thank you so much, Dr. Protas. I think you kept time like all other panelists. We continue to see the impact that the ARISE fellows are bringing in, and also capacity development in terms of training postgraduates. With this, I want to invite questions. Please raise up your hand. I'll recognize you, then make sure that you make your question precise, and just one question per person. And then indicate which panelist you want to address your question. I will start with you, then the mics can be distributed, and I recognize people as they get the mics.
Thank you very much. Paul Kelly from Zambia. The question is to the gentleman from, I can't remember where he's from, sorry, Burkina Faso. Anyway, my question is about Microsporidia. You were talking about using Microsporidia to control mosquito populations, but Microsporidia also infect bees. Are you absolutely sure that by controlling mosquitoes you won't cause a collapse in bee pollination? It's one of the online speakers, I think.
Can you please address it online? It was to who again?
One of the online presenters.
Okay.
Can you hear me? Please?
Yes, Bingo, we can hear you. Go ahead and address that question.
Okay, thank you very much. So this is really an interesting question and a really important question. So the Microsporidia that we are working on is not a pathogenic one. And this Microsporidia called, the name is Microsporidia MB. And this Microsporidia looks to be really specific to mosquitoes, and it's not like the previous one. This is a new strain of Microsporidia. It's really specific to mosquitoes. And unfortunately, I didn't get time to present the data, because what we have seen with this Microsporidia, even they are infecting mosquitoes, they are behaving in symbiosis with mosquitoes. The only interaction with mosquitoes with this Microsporidia is to block the development of parasite within malaria parasite within mosquitoes. So for the moment, this Microsporidia is really specific to mosquitoes, and the way it's transmitting is from mother to offspring. That means it's not like the pathogenic one, where when mosquitoes die, you can have spores on the body of the mosquitoes, and maybe it can affect another insect. But this Microsporidia is really specific to mosquitoes, and the way, I'm repeating once again, the way it's transmitting is from mosquito mother, a female mosquito, to its offspring. So it cannot be released in the environment.
Okay, like thank you, but please do test that. It would be a terrible mistake.
Thank you. Can I request Prof. Marine to come in forward so that any questions for her, she can address them?
Yes. I don't know if I respond to the question.
Yes, I think the person who asked the question is content. Next question, please distribute the mic.
Yes, thank you very much. My name is Dr. Norbert Dukuze. I have two questions. First question is for Prof. Martin. You talked about, I know your background is in virology, medical virology, but from your experience, we've seen that the pandemic, especially the COVID, we've had different pandemic before, like Spanish flu back in 1919, the cholera. but it seems like the population is not learning well from the history. As Africans, can you tell us maybe how well are we prepared for the next pandemic? The second question goes to Prof. Marlin. Thank you very much again for taking us through what Kenya is doing. Considering the maternal mortality, the current figures now showing that Kenya is 419 women dying per 100,000. It's sharing the same figures as some of the sub-Saharan African countries. What are we failing, considering the effort, but the result coming out of this? And you talked about precision medicine, but on this era we see that the African genome sequencing is low considering the Western population. What is your say also to this to increase the representation of African genome sequencing? Thank you very much.
Thank you so much for that question. I think we are at the post-pandemic era, and certainly most countries are very, keen to do the post-pandemic preparedness, and I think that was very well touched in the keynote lecture today. So there is a lot of resources that are being put by countries. We've under several countries that are investing heavily to make sure that any pandemic that may come post the COVID-19 pandemic is well taken care of even before probably it starts. So there are a lot of resources being put. There are organizations like the WHO, African CDC, that are investing a lot of money in countries and also in national public health institutions to make sure that there is genome sequencing facilities, and these facilities are not just there, but they have people who are incapacitated, equipped to be able to do genome sequencing and above it partake bioinformatics analysis so that they can be able to make meaningful use of that data and certainly track any kind of pathogens through genomic surveillance in real time. So there's money that has been put there. There's a lot of training going on in Africa to enhance that. We have partners and collaborators from Europe who are coming through heavily to assist Africans, organizations, and researchers to make sure that they are working with entities like ARISE and others, so that we enhance and capacity and make sure that there's enough training, there's enough resources, and also there's enough interest to make sure that this is being taken care of. One of the most funded initiatives is the genomics and bioinformatics, which I'm very passionate to. I hope I have answered that, but Marine can actually mention more on that.
Okay. Thanks for that question. Let me address the one on maternal mortality to start with. And as I said, we have really managed to reduce maternal mortality with 40%, which was never done in history. Why? Because it was very high on the political agenda. Right now, nobody talks about this anymore, but still we have 800 women dying every day because of pregnancy. So 2 big planes crashing, every 2 minutes a woman dies, but it's not a high priority anymore in the local and in the global agendas. And so one of the points is, if we really want to make a difference, we have to make sure that the country or the region that wants to make the difference put it very high on the local, the regional, and the global agendas. And that is a kind of a call from the countries, from the government. Because I think, of course, research has to be innovative and has to address new things, but also what we know has to be translated. Now, the case of Kenya, and Kenya is not alone, we started with like 365 deaths per 100,000 10 years ago. What we did is, what the government did, and the whole community is investing in, get more women to antenatal care. Did we do that? Yes. 60% 10 years ago, now 95% of the women go to antenatal care. Tick the box. Number 2, make sure that women deliver in facilities, not somewhere in the bush where they cannot get if they have a problem. Do women deliver in facilities in Kenya? Yes. More than 90% now deliver somewhere in a facility. So how come that we still have that huge number of women dying It's mainly because the quality of care of the facilities has not been taken care of. So before you had maybe 2-3 women coming per day in a low-level facility. Now there are 6, but it's still the same supplies, healthcare providers. So quality of care is number 1. Number 2, the most cost-effective intervention to reduce moms from dying is giving women the power to decide on their own reproduction, how many children they want, when, and that means also access to family planning. And that is in many countries, and not only because of governments, but cultures. Women agency, decision power is not taken care of. So we know what to do, but we have to keep it high on the political agenda. The genomics, you addressed that already, so I can be short. For example, diseases like breast cancer, it's really important to have more data from the African continent, because we know there are differences in genetic probability or like risk to get the breast cancer, for example. We know that, but we don't have many data from the continent. So this will also contribute. But again, even if you have the data, you have to make sure that you do something with it.
Thank you so much. I hope you are content with that. Any other questions, please? Yeah, there are quite a many. Just keep them brief. Distribute the mic, please.
My question goes to Dr. Protos. The herbal medicine industry is one that is quickly evolving in the African landscape. And there are a lot of concerns about the safety of this industry in terms of the implication on the health of people, because we are not too sure about the ingredients that are being used in the preparation of these drugs, the combinations and all that. And you are doing this excellent research to address this problem. My question is, what best practices should we anticipate from your research, and how do you intend to translate these best practices to the people in this industry? Thank you.
Yeah, thank you very much. I think when it comes to use of herbal products, they proliferate without control. So regulations must be put in place, and they are all pharmaceutical products. And of course, when you look at the dosing, it's a major problem. So there are 2 issues, the dosing and biodiversity. Because one of the things is what we are trying to do, you must struggle to get an experimental validation of indigenous knowledge so that you can do regulations. So those are one of the things. And then the second thing is, in order to control biodiversity, this is not sustainable. So you must look at a way where botanists can see those products that are used that can be cultivated for the continuous use, if at all they have to use that. Or otherwise, you look at, that's why we are doing, getting the molecules that are active, purifying and modify them so that you can be synthesized. You've heard of semi-synthetic products, so you don't have to go to nature. The population of the world is increasing, and of course, continuous use will mean that in a few years we'll not have that. So we need the regulations, and I think with the African Medicines Agency, that's one of the things they should look at. I know in West Africa specifically, and Ghana to be precise, that industry is a multi-million-dollar kind of industry, but it needs regulations. Thank you.
The next question, go ahead, please.
Yes. Thank you for giving me the opportunity. My name is Geoffrey Onaga. I'm interested in the presentation about surveillance using FTAs and saliva and honey. So how sustainable is this method, and how accurate is it, given that it's not only mosquitoes that feed on honey? And how can we tell that the variability that you obtain from such methods is mainly from the DNA from the parasite that you are investigating, not from other insects?
Is that a comment? Okay, good. So I'll take a few questions before then we will address them together.
Hello.
Because I see quite a number of hands. Can we start with Dr. Then we can move there. Then anyone else there, Bed? Yeah, and our colleague there. Let's take those three. Start here, please, with the mic.
Excuse me, I am asking about surveillance method that was used by Banda, something like that. I think he's online.
Oh, Banda, okay, good. I'll wait for you to be addressed, then we can have three questions.
Okay.
So,
Dr. Banda.
I have a more general question to three of the presenters, Dr. Bilgo and Tiam, on malaria. The question is basically, sorry. So currently, 1 or 2 years ago, I think maybe China actually was declared kind of malaria-free country, if I have a good memory. So my question is, can we learn something from what China did, or why should we develop new methodology in Africa? For three of you. Thank you.
Okay. I'll take two more questions, or three more questions. 1, 2, 3. Where is the mic, please? Yeah. Those are the last set of questions because of time. 1, 2, 3.
Thank you. I'm Noline Rakotwarsu. I'm a happy, active retiree from UNESCO, and I am here in my capacity of member of the SAC ARISE. My question goes to Professor Marlin, but also to the other presenters, and it's about the One Health approach. Because Professor Marlin, you said that we are now preparing for the next pandemic, and we have learned from the COVID that the One Health approach, which is an integrated approach, should be more used. So what is your view of that? Do you think that we are going to make more use of the One Health approach for the future, and how? Thank you.
John?
Okay, thanks. I'm Paco Sereme. I'm a member of the Governing Council of IAS. Really, it was a pity. I just arrived yesterday, so I missed a lot of presentation. But anyway, today I saw that the young scientists that are doing very well. And I just want to draw the attention on one presentation. I think it's Toei. You were concluding by saying that you need some advisory work. So that means the policymaker should be involved be aware on what you are doing. So that's okay. But what is the dimension of the communication on your project? Because you see in Burkina Faso, the dengue, actually people were saying that it is the malaria vector. And they are saying that because they are using modern technology to control the malaria insects, people believe that no, that is the dengue is coming from this situation. So you have to develop really a good communication. I don't know what was the proportion of the communication on your project, but I think you have to emphasize on that. So that is a recommendation.
In the interest of time, that will be the last
thanks.
question. Thank you so much for the question. I will have them addressed by Dr. Bingo, then the three of you will try and address the second question, then Prof. Marine will address the third question, and Gay will address the last question. Fine? Okay, quickly. The first one is online, Bingo. Go ahead. Let me go to the next maybe question, then you can continue with the second question.
is about. You can repeat the second question, please. About.
Okay. Okay, thanks so much to Dr. Paco for the concern about the communication of dengue disease. I think you are from Burkina Faso. I think last year we suffered a lot about the dengue disease. I think one of the big gap was the communication, because in the field, and then I think the population think dengue and malaria is the same disease. We are facing that information in the field. Even if when you are working on Aedes mosquito, you went to the field, they will say you cannot collect in my house because you are releasing mosquitoes which transmitting now dengue. I think the challenge for our scientists is to increase our communication and then to clear message about the dengue and then the difference between the dengue and the malaria.
The second question was about how we can stop malaria. I think 80 countries need to doing the strategy based in your reality. Because I can talk about Angola. In Angola, we have many problems with urbanization, with trust, and many things. I think for my conception, we need to stop malaria with diagnosis and treatment with high level, because asymptomatic patients, they help disease to, they help to infection more people. If we did the diagnosis early and the treatment early, we can stop this phase of the parasite, and we can be free of malaria in our country. Because another things need more work, and I think is difficult to stop malaria if we will solve all problem about malaria. Thank you.
Yeah, I think Euclid has said it. I think if we want to learn from what China has did, is to, first of all, what we need about malaria is to be able to control the disease first. After we can talk about elimination, then eradication. I think China even is far, but even Cape Verde last year has been declared malaria free. So that is a huge achievement, because Cape Verde is a neighboring country to Senegal, and it would be easy to learn from what they've done. And I think most of it is about urbanization. From what we've seen about Cape Verde, you cannot just throw trash anyhow in the streets or in things like that. But these are things that happen in Senegal and other African countries where we still have malaria. So as long as you are giving the vector the needs to develop, you won't be able to cut the transmission. And I think that's what we need to do first, and combining it to what the Bilgo has just presented about the biological weapons against those pathogens. I think we can at least control malaria and then use other strategies like vaccinations, chemo prevention to get rid of the disease in the near future. So that's what I have to say about it.
Okay, I think I won't be adding much. We understand the various control mechanisms put in place need different implementation strategies, and these national governments have different ways of implementing this. And for those countries that have succeeded in eliminating malaria, when you put the control strategies in place, they have effectively implemented some of those strategies. And of course, if the lessons are published, there are good lessons to be learned. Vector control, which you have different mechanisms, diagnosis development and drug development. Diagnostics and drugs might take time, but the better control might be very immediate. So we have to prioritize what is immediate, what are the consequences, and then you look the long-term diagnostics development and drug development, which take time, and look at strategies to shorten that period of doing, which is what some of us are trying to do now, such that developing drugs would be another control mechanism. I think if we do that appropriately, of course, policies implement, we would see elimination in many more countries. Thank you.
Chair has given me 1 minute to close. The One Health is a great concept. And I think we really have to continue to work there. We learned a lot with COVID, and there are many elements that we can, that feed the One Health concept, but it's still important to really well define it. Who are the players? Who is going to do what? Theoretically, it's great, but we have to continue to work so that it's clear for everyone. And I think what I presented, just to pay tribute also to Fadila, she was within the EC, the RTD, actually the motor, the engine of this collaboration with us, with the technical people. So I think we need more of this, and we need also for the other programs like ARISE and others, really to make sure that we co-create. Because very often we are from our own institution thinking we know what needs to be done, and we know a lot, but it's only by co-creation, and that's what I feel here today in this session, that there is so much potential here, so many young people who are really contributing a lot, and that is a step towards co-creation, which is key for the One Health concept. Thank you.
Thank you so much. Let's applaud these panelists. Yeah, so there was under very strict instructions to keep time, and I hope we did well. Thank you.
Thank you very much, Prof. Martin M. Nyaga, and all the presenters. Please, the organizers want that the coffee break be short. The organizers, it's not my words. The words of the organizers, they want that the coffee break will be short, so please, hello, hello. Hello? Hello? Do you hear me? Do you listen to me? Yeah. Hello? 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 Hello, please. Please. We have only few minutes of coffee break, so you can even bring your cup of coffee here. Okay? So let's take the break now. 6B, always in the same topic, research and innovation for global health. And I invite Dr. Roland Opisa from the African Academy of Sciences. He will be our moderator. He's here. Okay, so you invite the presenters?
Yes.
Okay.
Thank you so much, and good mid-morning. My name is Roland Opisa. I'm with the African Academy of Science in the Programs Department. Our efforts contribute towards the third mandate of the Academy, which is implementing STI projects and programs. And my main focus area is program monitoring, program evaluation, and program learning. I'll be taking us through session 6B, a continuation of 6A, under the HLPD of Public Health, Research and Innovation for Global Health. And I'm going to invite our PIs to give us spotlight presentations. First off is Dr. Emmanuel Amlabu from Nigeria. Welcome. To be followed by Dr. Daka Kasumba. Now, Dr. Daka Kasumba, for unforeseeable circumstances, was unable to be with us today, so we have a pre-recorded message from Dr. Daka Kasumba from the DRC. Third, we have Dr. Judikael Obama Nkonge, who will be joining us virtually. Dr. Judikael, please confirm.
Do you hear me?
Yes, we can hear you. Welcome, Dr. Judikael Obama Nkonge is from Gabon. Welcome. And lastly, we'll have Dr. Mary Obo from the Gambia. To start us off, we'll have Dr. Emmanuel Amlabu. Colleagues, we are 36 minutes past the time, so please maintain a perky pace. You only have 10 minutes. Welcome.
Good morning, everyone. My name is Emmanuel Amlabu. I'm one of your latest ARISE fellows at the African Center for Excellence for Neglected Tropical Diseases and Forensic Biotechnology at the Ahmadu Bello University, Zaria, Nigeria. I'm also an academic staff member at the Prince Abubakar Audu University in Ayimba, Nigeria. So, by way of introduction, I'm here to present a spotlight presentation on my work related to the development of novel anti-malaria therapeutics targeting Plasmodium falciparum lipid-binding proteins. So to start off with the talks, the development of novel anti-malaria therapeutics against the blood stage of the parasite development has been a very big issue. And this has been due to the following reasons. Number one, which I must humbly accept, these parasites or killer machines have become more clever than the scientists. The reason why I'm saying that is because these parasites have developed some extraordinary capacity to bind non-immune IgGs, with which they create immunological decoys that shields them from the host immune surveillance system. More interestingly, these parasites are able to secrete enzymes with which they can license merozoites for invasion, while a large repertoire of these merozoites are left exposed to burden the humoral immune system. Bearing this in mind, I would like to talk you through the processes of erythrocyte invasion which is a complex molecular process that involves ligand-receptor interaction occurring at the parasite host cell interface. It begins with a low affinity binding, followed by apical reorientation, followed by tight junction formation, which signifies that the parasite is committed to invade. During these processes, different ligands engage receptors that powers entry processes of merozoites into human red blood cells. After orientation, I mentioned the tight junction formation, which is moving, and then secretion of a number of ligands engaging appropriate receptors on red cells, and then gradually there's localized deformation of the RBC membrane, resulting in invagination and sealing of the merozoite, the RBC membrane. Parasite is internalized and formal invasion process is complete. This entire complicated process happens in less than 30 seconds, which leaves researchers with little opportunity to design effective intervention. We have looked at published evidences in the past which suggest that lipids or lipid-binding proteins may play an important role in the exocytosis of micronemes. These micronemes are secretory organelles that house most of the repertoire of ligands which I have shown in the cartoon simplification. Bearing in mind that phospholipid-binding proteins are responsible for exocytosis of micronemal discharge, we decided to integrate proteomic analysis with some data mining analysis supported by previous microarray experiments, and with inhibition-based assays, we are able to establish that these lipid-binding proteins could be potential targets. We deployed the CRISPR-Cas9 conditional knockout technology to define essentiality of these genes, and we found them with evidence that they are important for parasite multiplication or growth. When you knock out these essential genes, you see reduction in parasite multiplicity. With the ARISE project, I intend to use the GLMS technology to knock down these genes in the drug-resistant line, where I feel their effect will be more prominent. And again, the recombinant protein production setup has to be in place, for which the downstream objectives are dependent upon. Ultimately, we hope that we could design some intervention strategies that could combat lipid-dependent activation of drug targets. Just for you to know, this is the domain architecture of the target proteins. And to get this started off, we had established a recombinant protein engineering platform at the ASCENT TDFB Ahmadu Bello University, the host institution, which can service the country and other nearby institutions in the processes of serosurveillance studies, diagnostic platform, biosensor development for diagnosis, as well as therapeutic intervention. The photographs you are seeing is the first one is for my PhD student who is now a postdoc at San Diego, and the other is newly recruited PhD student that is about to start work with us. We have established that these proteins bind lipids by lipid overlay assays and lipid binding strips. Also, we have optimized binding of these proteins to lipids using biolayer interferometry and optical system, after which we have screened a library of 31 synthetic peptides, for which we found 4 of them to be high affinity binding peptides. The most potent of them all in binding we had characterized by high performance liquid chromatography and liquid chromatography mass spectrometry. What's the effect of this in what we are doing? We had also attempted to see possibility of these lipid binding proteins binding directly to these peptides in a view to quantify the binding in relation to kinetics. On the front of how related this project is to human lives. We have embarked on community engagement activities, advocacy visits, and proper engagement with members of the communities as reflected on the pictorial evidences. In terms of policy, the work on malaria cannot be overemphasized. It is one thing that has to impact positively on the life of people, and we hope that someday we'll be able to have something that could lead to a change in drug policy. Lastly, I would like to acknowledge my collaborators, Professor Geoffrey Chang at the University of California, San Diego, Shelja Singh at the Jawaharlal Nehru University in New Delhi, Professor Gordon Awandere at Wagbe University of Ghana, and Dr. Maurice Drake, visiting scientist at the Francis Crick Institute there in the UK. Others are my community engagement team members in Taraba State, which is 900 kilometers from the host institution, and my community engagement team members in Kogi State, which is about 600 kilometers from my host institution. My center leader at the Ahmadu Bello University for hosting me, and my vice chancellor at the Prince Abubakar Audu University for granting me the privilege to embark on my ARISE project at the Ahmadu Bello University Zaria. I wouldn't have come here if EMNA had not intervened in my visa rejection matters. I want to thank ARISE team members for making sure that they reverse the situation of my visa rejection. And I would like to thank you all for your attention.
Thank you so much.
Yeah.
Thank you so much, Dr. Emmanuel, even for saving us a few seconds. Now, we will have a pre-recorded presentation from Dr. Dakar Kasumba on investigating factors associated with Ebola virus disease outcome in patients receiving monoclonal antibody therapies. Take a listen.
Good day, everyone, and thank you for this wonderful opportunity to present our research here. My name is Dakan Kasumba, and I'm a lead scientist at the National Institute for Biomedical Research in the DRC, and I work on Ebola virus immunotherapy, trying to understand the mechanisms of resistance and propose ways to improve these treatments. Ebola virus is a virus that is known by everyone, I'm pretty sure, and it's a highly infectious disease, highly infectious virus, and with high mortality. So during infection, the virus uses its protein called the glycoprotein to enter the cells, and its other components, other proteins it produces, are also known to reduce or block the elements of the immune system, therefore weakening the host system and then causing disease symptoms that we know of. So the glycoprotein GP, and that's the protein that we are most interested in, is attached to the membrane of the virus, and it also expressed on the surface of infected host cells. The immunotherapy antibodies that were developed a few years ago were developed to bind the GP protein and therefore inhibit and neutralize the virus. So among the immunotherapies, there are two. One is called the MAB114, monoclonal antibody 114. It's now called Ansovimab, it's a commercial name, or Ebanga. In the presentation, I will be calling it Ebanga. The epitope for Ebanga is found in the receptor binding domain of the GP, of the glycoprotein of the virus. And Ebanga is known to neutralize the virus and therefore reduce mortality. It's been proven in clinical studies. The second immunotherapy is called Regeneron EB3. The commercial name is Inmazeb. It's a cocktail. This one is a cocktail of 3 monoclonal antibodies with non-overlapping epitope on the GP protein, as you can see in the illustration over here. This one also is known to reduce mortality in Ebola patients. So the question that comes to mind now, I'm pretty sure, is if we have immunotherapy that works, we have patients that are benefiting from this, why do we need to do more research in this point? So one point is that these immunotherapies are poorly efficient, so the efficacy is very low, very poor in severe cases of Ebola virus. So when someone comes with advanced disease, there's very little chance that it will benefit from these treatments. So we want to understand what could be the mechanism behind it and what can we propose to improve and give more patients chances of surviving from the disease. One hypothesis we have is the soluble glycoprotein. This is a form of the glycoprotein that is soluble and it is excreted, it is produced and by the infected host cells. It is a viral protein, and the protein carries within it the epitopes of a banga. So that means a banga can bind to it. Same for ansovimab. One of the components of our ansovimab can also bind to it, since its epitope is found in the soluble glycoprotein. The implication of this is that theoretically, as this soluble protein is circulating in the bloodstream, it can eliminate or reduce the efficacy of the monoclonal antibody treatment, the immunotherapy in the system. So to address this question, this hypothesis, we needed to develop a adapted analytical method. So we have been working in the past few years with our partner. We have been working for the past few years with our partners to establish a working ELISA that is adapted to our circumstances, due to this setup here. So we now have a wonderfully working ELISA setup. You can see here our standard curve with a wonderfully good linearity within the linear region of the curve. As we stand now, the patient samples from our biorepository are being analyzed using these analytical methods. Hopefully we will have interesting results soon to be bragging about. The second hypothesis we have is the possibility of escape mutations. So to give you to explain to you a bit what this means, as the patients are receiving the treatment, there's always a theoretical possibility that the virus can incorporate mutation and fix them in epitopes of the antibodies, of the monoclonal antibodies or the immunotherapy. The implication of this is that the efficacy of the treatment will be reduced and we will have less efficient treatments. But this has not been proven, so it's something that we need to analyze. So to give you a bit of background here, in 2018, between 2018 and 21, patients of Ebola virus were treated with Ebanga and Inmazeb in the DRC. That was during an outbreak, and this was part of a PALM study. That was a clinical study at the time. With our partners now, 22%, with the help of our partners, 22% of the samples from these patients who received Ebanga, and those samples were stored in our biorepository, and those samples were therefore sequenced by our pathogen genomic laboratory. What we found is that the sequences revealed no amino acid changes in and around the Ebanga epitope. This is good news. But this is preliminary, because remember, this is only 22% of samples. So we need to analyze more, and this is only 22% of samples from a Ebanga treated patient. So we need to do more analysis, more sequencing, and find out if there is anything. So this finding included different categories of samples regarding of the collection time. So whether it's pre-treatment or post-treatment, and also patient that clinical outcome as well that means patients who survived or those who did not survive the disease. So, like I said, more samples, including the regional untreated patients, need to be sequenced to be sure of what we are saying. So, in conclusion, Ebola patients' samples are currently being analyzed to quantify and evaluate the role of soluble glycoprotein in disease outcome, particularly in patients with severe Ebola disease. No evidence so far of Ebola-resistant variants to Ebanga has been found so far in nature, and this is also applicable for Regeneron. More samples to be collected from more sequences need to be collected from more samples. So we hope that from next year or by next year we will be able to collect more sequences. Furthermore, rapid real-time sequence monitoring of Ebola patients during outbreaks is critical as surveillance for possible escape mutations. And this is key for a quick response in case there is escape mutation. It is also key and important to continue supporting our research in this context. So continued support, funding and collaboration is critical to ameliorate Ebola treatment and prevent establishment of resistance. So I would like to acknowledge the following for the contribution to the ongoing research, and I thank you all for your attention.
Thank you, Dr. Kasumba. We appreciate him in his absence. We're going to have also joining us virtually is Dr. Judikael Obamen Konge. Are you ready?
Yes, I am.
Good, please proceed. You only have 10 minutes.
Okay, I'll try to share my screen. Please, are you getting my screen?
Yes. You can have it in presentation mode, please.
Yes, I'll view. Okay, I'll try. Yeah, presentation mode. Please, do you have it here in presentation mode?
No, not yet.
Oh, okay. And here?
Not yet.
Oh, so can I? Okay. I'll try to. And here?
Yes, please proceed.
Thank you.
Yeah.
Okay. Thank you, everyone. Good morning. And I'm Judikael Obam from Gabon, from the University of Science and Technology of Masukuso. I will be talking about the bioecological drivers behind the invasion story of the tiger mosquitoes, Aedes albopictus, in forests of Central Africa, and discuss some aspects regarding the One Health perspective. The Asian tiger mosquitoes is called Aedes albopictus. It is a mosquito that originated from the forests of Southeast Asia. Now it's a global vector of arboviruses, including yellow fevers, chikungunya, dengue, and Zika. It is now expanded all over the world, including in tropical and temperate areas. And why is this species so dangerous? I think one of the reasons could be found in that study by Vazel, who demonstrated that a mutation of the virus, for example, of the chikungunya, that has been selected by this species has been responsible of several epidemics, several outbreaks, episodes that struck different countries around the world. But if I localize in Africa, and particularly in Central Africa, we have several cases, thousands of cases in Gabon, in Cameroon, in Republic of Congo, and even in Republic of the Central African Republic. So this is why this species is so dangerous. And if we look at the history of the invasion of this species within the African continent, it started during the 1990s with the introduction of this species in South Africa. And in a time span of around 30 years, this species came through introducing in urban environments and to be observed recently in wild forested area, where most of the time the presence of human is nil, because this species is highly associated with the presence of human because of the use of artificial breeding sites. So the question here for this project was, what could be the impact of this species being invading a wide forested area, knowing that there is a lot of vertebrate hosts that could play a role of reservoir for various zoonotic pathogens, including arboviruses. So knowing the potential for this species to expand in new territories and its broad spectrum of vertebrate hosts. So the question was where to try to understand if this species has kept its potential to sustainably colonize the forest environments of Central Africa, and also to understand how breeding site features could shape its colonization capacity. And if you look at this picture, I would want to ask you, could you imagine having all of this on your body? And I can tell that this is exactly what happened to me when I first worked on that subject in the forest of Gabon, in the National Park of Flalopé. And the objective of that activity was trying to understand if these species could colonize the forest environments. And for that, we have conducted some field studies and field collection in the National Park of Flalopé, which is a village surrounded by different level of forest and savanna. And what we have found is that Aedes albopictus was present there, including in the village, but more importantly also in the wild environment, where the presence of human is very low or sometimes null. So this is to demonstrate that this species could lastingly persist in the forest ecosystem. Why? Because through all the collection session from, for example, 2014 until 2017, 18, even 19, we were able to demonstrate the presence of this species. Another thing is that its establishment in the forest environment may not alter its propensity to bite humans, because we have demonstrated that even in forest with human landing catches technique, this species was still able to bite humans. So this is now a danger for the human health. So the next question was to try to understand how this species could colonize this forest. And one of the questions was how breeding sites that this species can use could feature or could shape the colonization regarding the features of those breeding sites. And for that, we have conducted another survey with this ARISE grant, where we explored and we collected 271 water collection in the natural area, but also in the village. And what we have found is that 89% of the water collection were positive with mosquito larvae. And a large part of them was also found within the Sylvan area. That means in the wide forest. And what we observed is that regarding the positive microhabitats, the breeding sites, rock holes and tree walls was the most positive. So the question was, how was those rock holes and tree walls are regarding the physical characteristic, but also chemical characteristics? And for that, we have measured different parameters, including physical ones. And what we observed is that there was a large segregation of the physical features. For example, the diameters vary significantly from 5 to 21 centimeters, for example. Regarding the volume of water in the breeding site, we observe also a significant variation from, for example, 37 milliliters to 8,000 milliliters. The same was observed, for example, with the depth of breeding sites, and also the age from the ground, significantly varying from 0 at ground level up to 16 centimeters, even a bit higher for some specific breeding sites. So what we can retain is that the largest microhabitats seem more localized, all the same, within the village where we found humans. And this is because there is a lot of artificial breeding sites in the village. And also that the deepest microhabitat was also associated with those found in the village, but more interestingly, in the groves, in the forest. And lastly, that the highest microhabitat was also identified within the trees in the forest. And regarding chemical features, we Please wind up.
observe that
You have 1 minute.
Oh, okay. We observe also a large diversity and a significant variation of the chemicals within the breeding site. So I will try to speed up to the end. What we can return is that there is a kind of neutral appetence of regarding pH, for example, of Aedes albopictus in terms of association with microhabitats. And regarding the species, we have also observed that albopictus has a preference for granite and some plant essence. The conclusion of that is that there is a kind of selection of Pentacletra, Milosia, and Diospyros plants that could be of high interest in terms of adaptation for these species in the wider environment. And to finish, we also investigated which of those characteristics was influencing the most the colonization. And we found a significant segregation of the breeding site regarding their capacity of being artificial or natural. And we also conclude here that Aedes albopictus seem significantly influenced by physical chemical parameters and that the pH, the diameter, and the salinity and the conductivity has a significant effect on the colonization of this environment. So to conclude, I will say that yes, it's true, this species has the ability to invade wide environments, and that the microhabitat nature, size, and chemicals are key components. The next step now is to try to understand what are the host preferences of this species, and also trying to understand his vector competence regarding the transmission of viruses, and also the genetic structure to see if there is some kind of adaptation in terms of transmission of strains of pathogens.
I will finish here by saying thank you for this opportunity given to me to present the advance of that work and the project, and say also thank you for all the collaborators that are involved in this work. So thank you so much. And my apologies for being a bit longer than expected. Thank you.
Thank you, Judicael, and we say thank you for keeping time. So we'll have Dr. Mary Obo, our next presenter. Welcome.
Good afternoon, everyone. I'm Mary Obo, an assistant professor and senior research fellow at the Medical Research Council Unit, Gambia. I'll be presenting on my Rice Fellowship, which focuses on understanding the dynamics between Plasmodium falciparum, the causative agents for malaria infection, how this infection progresses and interacts with the gut microbiome. I'm looking at this in the context of the potential for diagnostic and therapeutic marker development. My colleagues and other fellows have presented on the devastating effect of malaria. Despite the control measures and finance that have been put into it, we continue to see that malaria cases has increased. It is not commensurate. The decrease in the cases that we have is not commensurate with the effort that has been put into it. This is both seen, also seen in mortality, especially in Africa, where we've seen a plateau in cases despite concerted efforts that have been put into it. If we zoom into this and look at the spread of malaria in terms of geographical location, we'll see that the sub-Saharan Africa suffer most from this infection. And if you zoom into the various countries, you'll see that 3 specific countries, Nigeria, DRC, and Uganda, contribute more in terms of mortality and the number of cases. So there are different reasons responsible for this, and different areas of research are addressing that. However, my research is addressing, trying to understand the interaction of the malaria parasite with the human gut microbiome. Several studies, specifically in mice models, have been shown that different types of microbiome have different interaction and relationship with the malaria disease progression. Either it protects against malaria severity or prevents against symptomatic infection. In some other cases, it has been shown to actually increase the risk for severity and or symptomatic malaria. All these are in the context of mice model. So taking these, I actually want to contextualize it in human model. And so the hypothesis here, which led me to this project, is that there is some form of interaction between the gut microbiome and malaria. And this interaction actually impacts on clinical manifestation. The overarching aim of the project is to evaluate the interaction and directionality of the gut microbiome and Plasmodium falciparum in malaria clinical manifestation, because actually there is no clear-cut direction of how one is impacting the other. So the project seeks to address that. The specific objective include to evaluate the gut microbiome signature that predominates in children with different clinical outcomes, evaluate the transcriptomic and regulatory profile of Plasmodium falciparum during and after malaria transmission season, to understand the antibody response dynamics of children with malaria clinical manifestation, all of them in the context of the gut microbiome. So leading up to the build-up of the ARISE Fellowship, I got a preliminary grant that was used to generate some preliminary data. And so because the idea to me, it seems far-fetched. So I wanted to be sure that there was actually something that might be happening there. So this grant was used to generate data from a cross-sectional study. So this study was conducted in the heat of malaria transmission. So where we looked at children with, sorry about this. So we have on the far left, we have symptomatic, children with symptomatic infection. And then we have those in the control. The far right is those on the severe arm. So when we did Cystinex RNA sequencing, we found that there are some signatures, specific microbiome, that leaves specific profile or indicators on these different children with these different malaria manifestation. We saw that, for example, the severe arm, bacteria belonging to the Enterobacteriaceae, Enterococcaceae, Lactobacilliaceae family were in high abundance in this group. And we saw the Clostridiaceae more in the symptomatic group. We now ask a question, can we zoom in and look at the different genera? Yeah, and yes, what we saw is that these families translate into different genera, and some of which have been known to be highly pathogenic. For example, Escherichia, Klebsiella, Shigella, and Salmonella were predominant in children with severity. We saw this, however, it's difficult to say which was impacting which. Is it the bacteria or the malaria that's impacting the severity? So there was no way to tell in which direction this is occurring. So with this ARISE grant, we're able to design a more elaborate study where we follow the children up from before they become infected with malaria, during the infection period, and after the infection process, a longitudinal study to understand the directionality and the kind of interaction that exists between them. So in terms of the transcriptomic and regulatory profile, to do this, first of all, bearing in mind that this study is a longitudinal study, what I did first was to mine data from databases, from SRI databases that have been submitted. So I got transcriptomic data and then conduct analysis, transcriptomic analysis. So what we saw is that in the context of people that have severe malaria, symptomatic, asymptomatic, and control group, luckily we're able to have such data online. We saw that there was a clear distinction in regulatory elements that predominate. For example, those with severe symptomatic malaria, they have, an abundance of microRNA. So microRNA are regulatory elements. They do not, are not translated into gene, but they control the regulation and expression of genes that leads to different inflammatory and pathological outcomes. So these microRNAs that we saw that 78 were upregulated and 63 were downregulated. So when we went further to probe the microRNA with different genes that are of immune relevance in malaria, we saw 6 to be very, I'm sorry I'm not showing them now, but we're still trying to decide how to go about it. But we saw 6 that were of very unique importance because they interacted with different genes that are of immune relevance in malaria immune responses. So we probe further this microRNA together with another kind of regulatory element, that is the long non-coding RNAs, and we saw that there was some interaction going on, but we were looking out for those specific 6 that we had already seen before, and then we saw that those 4 of those specific 6 also have some form of interaction with link RNA that have importance in malaria pathological outcomes. So we thought that both the microRNA and the link RNA, they have some specific markers in terms of pathological outcomes. But however, in the context of that these data were analyzed, it was not in the context of the gut microbiome, because it was a separate study. So having these data now available, we are going to, in the future direction of this project, profile the blood samples that we've gotten so far, trying to identify and see if, one, we can replicate and reproduce these microRNAs and link RNAs that we've observed in different databases. While in terms of the gut microbiome, we want to see if those different microbiomes they still exist and how they impact the interaction with malaria clinical outcomes. In this case, we will not just be stopping at the identification of the bacteria, rather we'll also be looking further into the different genes that these bacteria are expressing and the metabolites they are releasing.
Wind up.
Thank you. Okay, and further, we are also going to do, once we confirm with regards to the regulatory elements, once we confirm that they are reproducible in feed isolates, we'll carry out functional characterization to know how important they are in terms of distinguishing between the different malaria clinical manifestation. And lastly, we're also going to profile the antibody responses of the children during the 12 months follow-up period using the Luminous bead assay. In terms of the impact of the project, this project has been able to develop and is developing capacity. We've recruited 2 doctoral students, 2 master students. We have 4 research assistants. We have ongoing training on Python programming and data visualization with our doctoral students. We've organized microscopy training, so they are in the field now. We are finishing the sample collection in July. So they are identifying the parasite and carrying out the field work themselves. The students have improved writing and critical analysis of literature. 3 manuscripts are under review, all driven by the doctoral students. We've established collaboration, University of Calabar, where we have our samples being stored in the freezer under the right condition. Liverpool School of Tropical Medicine, doctoral students will be going there to spend some time to perfect their programming skill. London School of Hygiene and Tropical Medicine, master's will go there for the Luminous training. And then thanks to the ARISE team, they shared an advert sometime from the University of Groningen, Netherlands. We were able to identify a collaborator there that will also be working with our students. In terms of community engagement, we have quarterly malaria sensitization awareness and distribution of multivitamins to them. I'm grateful to the AES and ARISE team, the EU Commission for the provision of this one, and all the other partners for this fellowship. Thank you.
Thank you so much. So we come to the end of the spotlight presentations. We've been able to stay within our time limit, so we are only going to field 3 questions, 1 for each presenter except Dr. Dakar Kasumba, the research on Ebola virus. Please, 3 questions directed to each. So we have 1 directed to each. We have 1 there, please. And Dr. Judy Kyle, please, I hope you're still online. Judy Kyle, you can confirm?
Can I go ahead? Oh, okay.
Please, Bessie.
I'm Bessie Malila. I'm from the University of Cape Town. I've got a general question for all the presenters. Maybe just one presenter can address my questions. Focusing on the neglected tropical diseases is what these researchers are focusing on. But I've got a question. I think the last presenter did indicate that there is so much effort in terms of resources, financial and human, in trying to address this challenge of tropical diseases. Why are we still having this problem? Do we have any evidence of improvements, of impact of the efforts that are being put in? And what is the situation in other tropical regions? Is this problem unique to Africa only? And also, when we look at other issues that are being addressed health-wise, for example, maternal health, there seems to be good response to interventions or efforts. Do we have evidence of maybe improvements for tropical diseases? I think the problem also goes to HIV, AIDS, and TB, which is also very prevalent in South Africa. There's a lot of resources and efforts being put in. Where are we going wrong? Thank you.
Thank you. Paul Kelly, Zambia. My question is for Dr. Obo, which is some of the microbiome signatures that you were showing us are characteristic of children with severe acute and malnutrition and stunting. Have you taken nutritional status into account in looking at the microbiome composition? And that will be very important when it comes to looking at functionality.
Yes, Nkanga.
Okay, thank you. My name is Jean from the University of Rwanda. So my question goes to Dr. Mary. I think that you have been collaborating with local hospitals in your study. So as you have already identified 6 microRNA that could be a target, how are those hospitals able to consider those biomarkers in their usual or everyday diagnostic or therapeutic actions? Thank you.
Thank you. So allow me, Dr. Amlabu will respond to Dr. Besi's questions because Dr. Mary Obo has 2 questions on her plate. Kindly.
Hello. So, so far, the pre-erythrocytic stages of the parasite development, we already have 2 licensed vaccines for malaria. The only challenging stage is the blood stage, for which we have some candidate antigens. If you listen to Lati's presentation, you will have seen the RH5 penta complexes that are formed. RH5-based vaccine is promising until recently when we're hearing about the polymorphisms Lati is reporting, which is why the remaining 40 to 50% of the genes in the genome are being currently characterized in a view that we could find more unique antigens that could be targeted for either for either vaccine or drug development. So it's something that is still on the way going, but we have some lead candidates, which probably in combination with the pre-erythrocytic stage vaccines could lead to something great. Thank you.
And maybe the second question on whether it's only endemic in Africa?
Yeah. Only endemic in Africa, I would say no, because in countries like India, you have Plasmodium vivax, and most of the vaccine development strategy is focused on antigens that are conserved across the different strains of Plasmodium. And so we don't want to get ourselves into issues like production of strain-specific vaccines. We need something that has broad operational impact, which could address the pressing problems at hand. So in that case, no. We have other strains that are kind of causing severity of problems in other areas of the world.
Thank you.
Thank you. I'll respond first to the question on nutritional status. So in the first cross-sectional study, nutritional status wasn't considered. But in this follow-up longitudinal study, we are very careful. We have selected criteria that we are using to evaluate the nutritional status of these children, and to actually reduce the confounding factor of varied nutritional status. This study is conducted in one communal area where we are assured of the kind of food they eat and the value in terms of nutritional status of this food. And we have a nutritionist as part of the team with us who ensures that. So we are careful with that because we want to reduce confounding factors in this study as much as possible. On the question of markers for possibility of being used in the hospital, and we're still a very long way from that. Right now, we are trying to reproduce the in silico observation we have with field samples. That's the first one. Once we are able to reproduce this, we'll have to functionally characterize this and see the effect. So we are looking at both human and parasite. So with regards to human, the focus is on diagnostic marker. With regards to the parasite, the focus is being used as a therapeutic target. So while we are still doing that, we are still a very long way from these microRNA and or link RNA being used as a marker, because we have to, first of all, functionally characterize them. And then we can now move forward with other areas, biotechnology development and all that. Thank you.
Thank you, Mary. Thank you, panelists. And with that, we are going to move on to the next session. Let's applaud. Thank you so much. To the MC. I could gladly invite Professor David Onyango for the next session. Welcome.
Okay, good afternoon, everyone. I will want to start by saying that we are 36 minutes late. So when I keep you here for 36 minutes more, don't complain, please, because we are 36 minutes late. 46. No, 36. So your lunch will be 36 minutes late. So don't complain. Thank you. Okay. Thank you very much, everyone. As you have been told, I'm David Onyango is my name. I'm a professor of cell and molecular biology at Maseno University, Kenya. Here I stand because I do some research that are in regard to cancer. I look at molecular mechanism of cancer in liver and prostate. That's my area of research and expertise. And so here I've got only one thing to do, and which is to basically ask questions. The way I've been asking them on the floor, now I've got the privilege of now asking people questions so that they can give me answers. I've got 4 panelists that I'll want to call upon to come here so that we can have a discussion, a round table discussion. I'm sorry, our MC, you will have to help me, yes, because I don't know how to pronounce these names. Yeah.
Hello. Excuse me, I was in the swimming pool. I was swimming. It's too beautiful today, better than yesterday. So, thank you, Professor David Onyango. I will call Professor Heshmi Louzir, former director of Institut Pasteur de Tunis and director of the national campaign of COVID-19 vaccination from Tunisia. مرحبا سي الهاشمي. Dr. Mariam Khrouf, Director of Medical Research in the Ministry of Health, Tunisia. Professor Marlene Temmerman, Director of the Center of Excellence in Women and Child Health and Chair of the Department of Obstetrics and Gynecology, the Aga Khan University, East Africa, Kenya. She was here a few minutes ago. And Professor Fadil Esop, President of the African Association of Physiological Sciences from South Africa. So please call Professor Marlene Temmerman to come here and we can start. Thank you very much.
So is she coming or we can start?
I think you can start and we will join her.
Thank you for that. Let me get the set of questions that I'm supposed to ask my panelist. Okay, great. So, thank you. Thank you. Thank you for this. Now, we're going to have two sets of questions to each panelist, and we want to ask the questions in regard to the names that I was given. I'm sorry about that, because here the list that I have doesn't have the names. So you'll bear with me. Your 2 minutes again is being eaten. So worry not. Worry not. No, I'm looking for the questions. I've got the questions for them. Okay. Yes, I'm sorry about that. Don't worry not.
This is the first question for me.
Worry not. I'm going to, yeah. Yes. Great. Thank you. Yes. Thank you. Thank you, Obed, for coming to my aid. Okay. I've got 4 panelists. Thank you very much. I'm going to ask you each one question, after which you'll answer. I go to the next panelist, ask you another question, you answer, and I'm going to give you 5 minutes, please. So make your answers very brief. It's 5 minutes. My first question goes to Marlene.
Yes, sir. President.
We are discussing on the aspect of the needs and technologies for health societies with the respective, with responsive and resilient health systems. So we are looking at the needs and technologies for health societies with respective and resilient health systems. So your first question comes, What are some of the most pressing issues facing Africa's health sector today? What are some of the most pressing issues facing Africa's health today? 5 minutes, please.
5 minutes.
Yes.
I'll try. So I think there are many pressing health issues, and we can just look at epidemiology. What are people, what is the mortality, morbidity, what is the burden of disease in African countries, and not only in Africa, in Europe, everywhere in the world. That's the way you should look at it. Then put your priorities. Put the priorities where the people actually suffer. What we do many times is we look at the burden of disease defined by one interest group. And we don't look at the population level, right? So that's what we should do, and it's actually the governments who should be, or the regions who should be in charge of that. We have done this in Kenya in several counties, working with the Ministry of Health. What are your priorities? In Kilifi County, for example, number 1 was road accidents, mortality. Number 2 was malaria. Number 3, HIV and maternal health and so on. Then you look at the research community. Where are you focusing your research? And there was very little. In some areas, yes, HIV, a lot of input. Road accidents, nobody was actually focusing on that. So what I'm trying to say, the priorities, in my view, should be defined by the countries and by the region. And then in collaboration with, they should be in the pilot seat. And the partners, the stakeholders, being finance agencies, being philanthropy, being the researchers, the communities, should work with the governments towards their goals and to the commitments. Because very often, a leadership can make a commitment. Let me give an example of the Millennium Development Goals. How many countries in Africa have reached the Millennium Development Goal 4 and 5, children and women's mortality? Only 2 countries. If you look at those 2 countries, because we did an assessment, it's because the leadership of the countries, not only the Ministry of Health, but the highest level were saying, this is for my country a priority. Bringing together Ministry of Health, Ministry of Science and Technology, Ministry of Education, everyone who is involved in this area, together, Treasury. So if that leadership is there, then all the partners can work around these specific topics and can commit. And then the commitments are there. Very often we work in all kinds of directions. The government says this, philanthropy, people with money have other priorities, stakeholders do something different, research communities are not aligned. So then we go in all directions and we don't move forward. So we really need to think it. And then I think also the donor communities, the strategies, the strategic partners have to be willing to put their efforts together. And I'm very happy to see that this is happening more and more and at the country level. For example, maternal mortality, again, there is now a strategic thinking with the US, with the EU, with the major partners who are saying, yes, we are willing to contribute into that area defined by the government. And that makes a difference. And there is a lot of evidence. We have done investment cases with the UN showing that this really makes a difference. But when we go all our own directions, what we often do, we keep on piloting and we keep on doing projects. Every project, we are all in projects. We get funding for project 4 years, 5 years. In the best case, we write a report, we disseminate, we publish, and then 2 years later, another group starts doing the same without knowing what has been going on already.
Yes.
So we suffer of pilotitis, we pilot over and over again, but don't use that information to move forward. So keywords for me are the countries, the ones who have, in the pilot seat, leadership in the pilot seat, everyone around the co-creation of an agenda. And co-creation is more than, when we co-create, we call it co-creation. We co-create a project. What does it mean? The research community writes a project. Then we ask a letter of support from the ministry. And that's what we call co-creation, right? That's not enough. It's really working together, and maybe even if your agenda is this, but the government has other priorities, and say, well, yes, okay, let then other partners come in and follow the guidelines from the leaders.
Thank you. Your 5 minutes are over. I want to ask the second question, and the second question goes to Fadile. Fadil, I want to believe I've pronounced it correctly. Your question goes like this. What are the most critical imperatives for strengthening Africa's capacity for sustained, integrated, coordinated, and collaborated research, innovation, and translation for health? I'll repeat. So please be keen, because the question is too long.
Thank you.
Yeah, I am going to repeat for you so that you get to listen to get the question clearly.
I think I've got the gist.
Oh, you got it. Thank you. Thank you. Go ahead and answer. So you have got 5 minutes, starting now.
Yes, so you're looking at solutions potentially for addressing some of the health challenges on the African continent. And firstly, the challenges for me would be lifestyle-related diseases, non-communicable diseases, diabetes, cardiovascular complications, because the world has become small and we have similar foodstuffs we eat, the youngsters, YouTube, people sitting. Sitting is the new smoking, for example. We've sat the whole morning, so that's just added to our burden of disease. So perhaps in the future we should have treadmills as well at our meetings, because we're actually adding to that complication. In terms of solutions, I think a lot of the talks we heard today focused on precision medicine. So we try and work on the genes, and we try and work on the proteins, we try and work on all the omics, so to speak, metabolomics. But that's only a component, I believe, of a bigger aspect of managing health as we go forward, and that would be personalized medicine, which would look at an individual or a community in a holistic sense. In other words, that we live in an environment and there's multifaceted issues that would feed into the health and well-being of those populations. It could be simple aspects such as clean water, housing, pollution, stress. It's a big thing. Mental stress, mental well-being, in addition to the genetic predispositions that we've heard about in the discussions, to find suitable targets. So I think we need a holistic approach, would be my answer. That would mean, in terms of working together, multidisciplinary type of teams tackling health issues. So you've got your scientists, biomedical scientists, as we've got the ARISE fellows, but in addition, science diplomacy, science communication. Get the communities also involved as partners in our research. As we heard yesterday, one of the talks, and not as passive bystanders. Look at indigenous knowledge systems as well and see what that may offer us. Instead of us coming there with, this is the only view, science from a Western perspective, or the roots at least. And then I think we've got to look at the training as well of our scientists. I think there's a knowledge gap at the moment because it's strongly inward looking. So that we mention that, you've mentioned, for example, get involved with politics. But the system does not allow that really, because you've got to publish or perish, for example. So when will you have time to get involved with other aspects? Because you're driven by a system that demands certain outputs. As we've seen each presentation, people put that at the end. So we've got to create spaces for people to have in their training components of science diplomacy, science communication, the historical roots of, for example, colonialism in science and medicine, so that we understand where we come from, where we're going to, structural issues in society. So how many minutes have I got left?
About 2 minutes.
Oh, I can see
Yeah.
the time. And that we consider all of those facets, so you train holistically qualified scientists. Even have them do some diplomacy so that if they want to venture entrepreneurship into those areas, they're fully equipped. Versus at the moment, it's just domain-based. You become an expert in malaria, you're going to be inward looking, and the chances for you actually impacting more broadly, as we've seen in your case, it's perhaps the exception, if we take the science community in general. So I think those would be my suggestions going forward.
Thank you for saving us 40 seconds within your time. Now, I want to go to the third question that goes to the third panelist. The question goes like this. As we intensify scientific cooperation and facilitate mobility of human talent, how do we effectively shift from the traditional brain drain and brain gain to brain circulation? Thank you. 5 minutes starts now.
Thank you very much. So my name is Mariam Khroufa. I think that you have got difficulty to pronounce my name.
Yes.
I'm the the director of medical research at the Ministry of Health in Tunisia. And this is a very burning question, brain drain. So especially for Africa and low and middle income country, where training health professionals and doctors is very expensive for such countries, their departures to other countries will generate understaffed hospital, and the remaining health works will be in burnout. So it's a vicious circle because condition will be not very good, and the quality of care will also be affected. So we will get new departures seeking new opportunity and better condition. So shifting from to brain circulation is very important approach. And to attain this goal, we need first to address root causes of the brain drain for each country, because there is specificity from country to another, and try to find solution for those causes. Factors are known and are various. There are people who go to get a better job, better economic opportunities, better careers. They seek also for a better opportunity to have specialized, highly specialized training. And of course there is other reason like social quality of life, culture, everything. Sometimes reasons are providing from their own country. For example, if I take Tunisia, for example, biologists, geneticians, they haven't the right to be employee in clinics. They haven't the right to work in a technical platform. So with the arrival with the sequencing and new generation, investment are very costly. So it's easier to go abroad and to be to get salary in a clinical in another country. Sometimes solutions are simple to retain highly skilled profession and to attract others from other countries. It's important to emigrate temporarily, to work in an international system and to interact with the people from a developed country for transfer technology. This is, of course, we need to implement collaboration between countries to facilitate visa, permit residence, work. permit. But we should work on a temporary way, and we should work on manner how to get them back to their country, to implement what they have gained in expertise. And generally, they would like to improve their country, because in developed country they are part of a system, but in their own country they are people who build the system, though is more prestige. So we should work on this point, and to attain this goal we need to put a national strategy to monitor people who go abroad, and to assess how, when they came back, how did they implement what they have learned. We need to work we need to insist in international cooperation, and we need planification for each departure. We need to planify the future of this person who will go abroad, and what this person will develop, and how this will meet the need of the country, the country. And we need to also work on motivation. So
please,
they can
you summarize, because your 5 minutes are over, please.
Okay.
Yes.
So 10 seconds. 10 seconds. We need to put incentives so they can come back, and regulation. And the best example is Spain, how is a platform for fertility, because the regulation is very easy. So all European country, all researchers and doctors from European country go to Spain to gain in this expertise. So we need together to work to develop expertise center, and of course we need to put a system in Africa, and Tunisia have the chance to be part of Horizon Europe. So we can work together to more collaboration and implement expertise center. Thank you very much.
Thank you for that. I want to go to my fourth question, and my fourth question goes to Hemi. Hekmi. I want Heshmi. Thank you. Some of these full names are very hard for us to pronounce, especially for us who are coming from East Africa. Yeah, the East Africa, we are not used to such like names. Anyway, that notwithstanding, we are moving on. Our question number 4 is goes like this: While considerable progress has been made towards promoting equitable knowledge exchanges between Africa and global North, inherent asymmetries still exist. What can we learn from Tunisia's national campaign on COVID-19 vaccination?
Thank you
Yes.
for this question. I want to start by the fact that indeed COVID-19 has taught us a lot of things, and we hope to put them to good use for better preparedness and response. This is applied for many countries, and how to valorize the experience learned during COVID-19 for preparing the future. I selected some point that can serve as something that we learned. First, I start with the diagnostic. Now, very quickly after the beginning of the pandemic, many laboratories used the real-time PCR. Just before COVID-19, at least in Tunisia, this technology were used by only 5, 6, 7 labs, and mainly research labs for the expression of gene, etc. So now it's used and democratize it in many public and private laboratories in the country. And this is something important that we learn this and we set up this kind of technique. So this is very important. Now, this lab could use this technology for the diagnosis of other infectious disease. The second point in Tunisia is the information system for many activities. And especially, I want to give the example of EVAX. EVAX is an electronic platform for vaccination. It was used in Tunisia. This application is developed and deployed 100% by Tunisian skills. It made it possible to manage the entire vaccination process from registration to prioritization of the people who will get the vaccine, invitation of citizens, vaccination, and the issuance of a standardized, secure, digitalized vaccination passport recognized by the European Union, leading to one of the highest vaccination coverage in Africa and Baden. So, with this high usage rate, the Tunisian has demonstrated that he is connected, and many other countries, I'm sure, in Africa also, and many other. So people are connected, especially young and digital, and ready for the generalization of digital services. That alone is a great lesson from COVID crisis. I want to now to cite one other, and for me it's one of the most obvious lessons learned following the pandemic, is the urgency to develop local production of vaccine, especially in low and middle income countries. Africa produces less than 1% of its need in vaccine. Vaccine production by wealthy countries, especially for COVID-19, for example, prioritizing governments that could pay the highest price and made it clear that low and middle income country was not the priority to receive this anti-COVID-19 vaccine, while the WHO has continuously advocated for equitable sharing of vaccine through the COVID facility. I would like also to add that access to vaccine is not dependent only on the availability of vaccine, but also on all the logistics of vaccination, health system, cold chain in particular, and on the acceptance of being vaccinated. I know that for some places, and unfortunately in some African countries, the problem was not the access to vaccine, to get the vaccine, but the process of vaccination because of the problem in cold chain and other factors. So following the success of mRNA vaccine, the idea of promoting this technology for the local or regional production of anti-COVID-19 vaccine has emerged, and the creation of the mRNA technology transfer program is a valid strategy, and we are certain that this technology holds great promise to improve access to vaccine against many diseases such as malaria, leishmaniasis, tuberculosis, rabies, and cancer, that are more frequent and more present in Africa. And to decline this for more precise strategy and to propose this, may I have a slide, please? There is one slide here.
There's one slide here. But your time is over, so...
Yes.
How are you going to utilize that slide?
This one.
Yes.
Yeah, so I have the pleasure to be part of this paper with the group of scientists and immunologists from Africa. Many of them are from South Africa and other countries. And in this paper, we describe the opportunities and challenges of leveraging COVID-19 vaccine innovation and technology for developing sustainable vaccine manufacturing capacity in Africa. And there is more detail inside this paper. If I have the next slide, just to summarize, this is the, let's say, the sustainable vaccine development in Africa. We require the establishment of a continuum of activity. In blue, spanning the entire value chain, substantive investment in fundamental research, shared toward vaccine discovery will be needed to populate the pipeline for downstream evaluation and eventual production. In the short term, which is in green, we can, the manufacture pipeline will focus on manufacture and distribution of vaccine developed elsewhere. This is the first step. And I will stop here now, and I'll wait for your next question.
Okay, thank you. Thank you for that. Thank you. I'll go to the fifth question, and my fifth question goes to Fadile. Here goes the question. There is growing recognition of the impact of social determinants in improving healthcare systems to achieve health equality and improve population health. What are the current shifts in policy on social determinants of health in Africa?
Thank you, Chair. How long do I have? How many minutes?
Your 5 minutes starts now.
5 minutes. Okay.
Yeah.
So just for the audience, then the social determinants of health, we're referring to aspects such as educational attainment, housing, what else? Stress, pollution, all of those factors that would ultimately influence the health and well-being of a community and of a population. And so I just want to stress that this is a very important aspect of disease, and it's emerging now, as the question was put, as an important aspect to focus on. In addition to what we've heard, we haven't heard many talks today, for example, in this regard, that we need this in addition to the physiological, the biochemical, and the genetic aspects that we investigate. I include myself in that, in terms to understand disease etiology better. So that would be linked to policy by governments, because it's linked to broader aspects such as if you live in an environment, and often this would be divide in terms of the divide between rich and poor as well comes in here. And for example, I live in a country with the highest, they call it the Gini coefficient, that would show the wealthy versus the poor. We've got the highest in the world, others such as Brazil, likewise. And even in the United States, you'll typically find that those who live in poorer areas will be worse off because it's structural. So if you look in the US, for example, people with dark skin complexion would not have any trees in their environment. So they would be exposed to extreme heat. You could be located near an area with a factory that's spewing out pollution into your neighborhood. There's no green parks for recreation. So all of those factors would fuel disease ultimately. And what's really interesting, before I get to the policy, is that the lack of these social determinants are now actually linked to genetic and physiological changes. Interesting. It's not only that you're exposed to that, it could even be racism. In that because our genes, we've got certain modifications to that genetic code known as epigenetics. So that the genes get modulated because of certain environmental stressors that you face. And because of that, even during pregnancy, there's some fetal programming occurring because of your environment. So this ties the environment very closely to the physiology and the biology, so that those genes are altered, and so the expression of those proteins are up or down regulated, and that ultimately can impact on your risk for the future onset of certain complications, whether it be diabetes in the future, obesity, cardiovascular, because of your environment. The question for me is tough because I'm not a politician. I think the audience are smart enough to know that it's not going to happen as it should, because often, unfortunately, the politicians are also in the pockets of the wealthy who gets taxed less and favors in return. So I don't have the answer, I'm afraid, on that question, but it's a crucial question. I can stress that we're seeing now how the environment is also linked to the physiology and the genetics. And that to me is really a major concern. We can only come up as scientists with interventions then, because with exercise, try and change the environment as best as we can, lobby with NGOs and other societies and organizations, and try at a local level to perhaps change it as best as possible. Then we need to get the politicians involved. My colleague may have more experience with that. Do you want to add?
Yeah, she's donating.
40 seconds.
Yeah, you
yes.
have got 40 seconds. Yeah.
That's why it's so important for scientists to work together with other constituencies, with politicians. And you everywhere in the world you find the ones who are interested, but to provide them with the language and with the messages that they can use. Right? Not a complicated scientific language, but communication is key, so that the message is very clear to them, and to work with them from scratch, actually. There are a lot of examples of success. And yeah, I think that's what, not everyone has to become a politician, but working with politicians, and you have to build that up, because you have to know each other. And it's not only with the elected politician, but also with their administration. And so you can reach someone.
Yeah, the 40 seconds are over, please. So let's move on to the next question that goes to Hekumi. Yeah. Please, with the increasing frequency of pandemics and health emergencies, there is a greater emphasis on the strengthening global health security. What is the status of Africa's health security and preparedness as compared to the rest of the world?
Okay.
Yeah, 5 minutes starts now, please.
Thank you, thank you. So Africa, faced with pandemics and health emergency, these are unique challenges for Africa. There is also some notable progress. I can say straight away that there is no comparison with developed countries in terms of efficient health system, unfortunately. The situation in Africa is found in other developing countries. International cooperation and assistance play an important and sometimes ambiguous role. I will go to this point later, but in some cases it helps fill gaps in Africa. The challenges, there are some disparities. We cannot consider all the countries in the same situation, but the big challenges, especially in some countries in Africa, is first, the health infrastructure is limited in many African countries. Restricted access to hospital, medical equipment, and essential medicine, unfortunately. There is lack of qualified health professional, not in all places, but in some places, even inside some countries, there is lack of qualified health professional, including doctors, nurses, laboratory staff, including technicians and engineers, etc. Health financing is often insufficient. The budget, the part of the budget dedicated to the health system, the health ministry, etc., is not enough to support all the problem of health, especially now with the increase in the cost of health, medicine, vaccine, etc. Disease surveillance systems are insufficient and non-coordinated, and there is no big coordination, unfortunately, between some countries, because disease, they don't have borders, especially infectious disease, so we need to have more coordination. Access to vaccine, diagnostic, and treatment may have limited by logistical, financial, and infrastructure factor. There is some studies that indicate and show that if in the future Africa will not be able to produce diagnostics, medicine, drugs, and vaccine, it will not access them soon. So we have to develop this for African countries in general. And I go to the progress. There is some progress. fortunately. There is awareness of the need of capacity building, particularly with the support of WHO, UNICEF, African CDC. There are also some training programs for health workers. I am speaking mainly on health system and not too much on research aspect, which is so we need to have more effort in the health system. Some technical innovation exists, but remain limited. Telecommunication, infectious disease surveillance in some places, some effort in rural area, very promising and ambitious program for vaccine manufacturing in Africa. There are many programs, the mRNA Hub and Spokes initiative, etc. There are also a certain regional initiative, the African Epidemiological Surveillance and Response Network, the African CDC program. They have many programs, but we are still waiting some concrete action, but they started. There is some activities which is very important. Now I have some recommendations that are in the slide. Please, if we can put the slide.
Yeah, you have 1 minute left, so can you please
okay.
Please beam the slide here.
In fact, these recommendations are largely inspired by the excellent, no, it's not one.
The next one?
Next. The last one. Okay. These recommendations are inspired by the excellent work done by Ibrahim Abubakar and collaborator that was published in Lancet in 2022, which is the study, in fact, the results of the Lancet Nigeria Commission investing in health and the future of the nation. I recommend the lecture of this paper because the problem that were discussed for Nigeria could apply for many other countries in terms of how to improve the health system. And we need, the first point, a social contract centered on health, and the prevention should be at the heart of health policy given African young population. 2, many African countries needs an ambitious program of health care reform to deliver a centrally determined, locally derived health system. At the same time, the system should encourage innovation. Innovation, it means how to make, let's say, research and discoveries to the field to apply for the diagnostic, vaccine, etc. We should improve health financing and ensuring better distribution of resources. We envision a future of African health without foreign aid. Foreign aid had led to fragmentation of the already complex health development landscape with the huge asymmetries, illegitimacy between foreign actors and the nationals. We have some problems in some countries. Africa needs better manufacturing capacity. I spoke about this for essential health products, medicine, vaccine, and diagnostic, and I stop here.
Thank you very much. So, can you have a round for them? We have gone through the 6 main questions that were to be asked to the panelists, and we can see that from what we have in regard to the needs and technologies for health societies with responsive and resilient health systems, what is coming out very clearly is in regard to 6 major issues. One of the issues that is coming out clearly is the fact that we need to define, countries need to define their research priorities and areas in which they want research to be done, and also areas that they want to health issues to be taken care of. So the panelists brought out clearly the fact that we need to define health priorities country by country. That's very clear. The other aspect that came out is that we need to have a holistic approach to health issues. holistic approach to health issues, whereby we look at health holistically, not in silos. And also, we also required to use indigenous knowledge. So we also need to use indigenous knowledge, and also we are supposed to train our scientists. Training of scientists is also very pertinent, it's coming out strongly. The third aspect that is coming out of the discussion that we have had is that we need to address the root cause, root causes of brain drain. What are the root causes of brain drain in our countries? And then once you have decided or determined the root causes of this brain drain in our country or countries, then you need to come up with solutions, because you'll know what the problem is, and then we should also have solution to them. So that's not an issue that is going to be done by any other person or anybody else, but it has to be done internally. We're also seeing the fact that there has to be a national strategy to monitor those who are going abroad. This is very, very clear. So our countries need to have a national strategy of monitoring those who are going abroad. I can remember when during my time when I was doing a PhD, one of the conditions that I was given was that if I go out there, I have to come back home. And when I was outside there, those people who are by us also ensured that I had to go home. So I had no otherwise, I had no choice but to go home. So one of the things that is coming out here very clearly is that you must have a national strategy to monitor those who are going abroad and see that they can come back home. And you're also seeing an aspect of we need to have an introduction of high-ended technologies to help us solve our health problems. So we need to have high-ended technologies to help us solve our problems. For instance, currently, after the COVID, one of the panelists has said that the use of PCR, the use of those high-ended technologies in our hospitals has been highly embraced and uptaken. So that introduction of high-ended technologies in our hospitals is needed. We also need to have or to develop products for Africa. Africans develop products for Africans. Yeah, that's a point that has come out very strongly from our panel, that we should develop products for African by Africans. As we conclude, we also realize that government policy is an issue that needs to be attended or addressed very effectively. And the issue of health infrastructure. There is a problem with our health infrastructure, which is limited, and so these health infrastructures need to be beefed up, yeah, or improved in one way or the other, so that now we can harness the full potential of the health system. There's also lack of qualified health personnel. That one came out from our panelists, that this lack of qualified health personnel. And this is subject to debate, because in most cases we have got brain drain, we have got our nurses, our doctors going abroad. So when you say that we have got lack of qualified health personnel, that is debatable. But because it's something that has come out of our panel, we take it as it is, that we need to train qualified health personnel, personnel, that is, in terms of doctors, nurses, technicians, wherever. The issue of health budget also came out very strongly, yeah, that we have got limited health budget. And so this is now goes to aspect of politics, because if you have to influence the amount of money that's going to be released for health, that now goes to politics part of it. So health budget need to be increased. There has to be coordination of surveillance. This I thought was very, very strong because they are saying there's no coordination in disease surveillance. So whatever happened in my country, for instance, in Kenya, is not known by my colleagues who are doing some work in Gabon, in Togo, in Senegal, Gambia, South Africa, something like that. So the aspect of coordination of health surveillance is very, very important, and this will call for a consortium of researchers working together so that this can be achieved. So without much ado, I know I've taken much of your time. So the 36 minutes have been increased to 40 minutes, don't worry. So I want to end this session here. And before I end the session, I want a very, very big round of applause to my panelists. Thank you very much. Thank you. So I hand over this session to the MC. Is the MC around or is still in the swimming pool?
Hello.
Thank you.
I'm dry. So there is no questions from the audience? No?
No questions.
Okay.
Yeah, there's
so
no question from the
we
audience.
take a lunch break for 45 minutes and we come back. Thank you.